Thank you, everyone. Tamasoma Jyotirgamaya. Okay, so without wasting our time, because there are a lot of attendees online, we will start with our academic sessions. And you, Dr. Chepsi, not come. Oh. So we will start with a mixture of a session from the pathologist and her clinician. So may I take the honor of welcoming on stage Dr. Rajalakshmi and Dr. Mahesh to present their case, please. Huh. Yeah, before that, I am extremely sorry. We have a welcome from our managing director, Mr. Stephen. May I welcome Mr. Stephen to please come on stage?
Hello, everyone. Good afternoon. Namaste. Okay, I'm Stephen, the Managing Director of Mindray India. For me, it's the first time to come this so beautiful city, Cochin. And it's the first time to makes me to meet so many good friends, Mandray's friend, and welcome all of you to attend this symposium. For Mindray, we are a company located in Shenzhen. It's a global international company established in 1991. Currently, we have the 3 product line business around the world. We export more than 190 countries and regions. So right now, we see that today here in IVD business in India, we grow a lot. But this all growth, we thanks the support from all youth. With your patient and trust, Mindray can grow like this way. Right now, from global wide, Mindray is trying to do more international. Here right now in India, we have more than 180, almost 200 employees from local. We have 4 branch office, Delhi, Mumbai, Chennai, as well as Calcutta. So with this localization is a stage 1, and stage 2, we also have very good local partners, distributors. And we are going to do the localization for manufacturing in India. With Mandray's growth in the last few years, we set a target in 2020 to be the top 20 in the healthcare industry in the world. We will make it in this year, and we are continuing to be the top 10, our new target in next 5 years. With this good target, Mindray grows with our own product, the business. Definitely, we are going to acquire and merge new business, new technologies, such as maybe you know that from the high test from Finland, which is dedicated for the raw material in the reagent, as well as the German company Diagnostic in the biochemistry technologies. So with all good technologies, good companies, we are keep continually to doing the investment for the business. This time, the cube we arranged here today, I think our main topic is about the patient safety and patient care. So fast response from our technologies can reduce the turnaround time of the patient to diagnostic. So mainly maybe later, our all KOL speakers will show the information today. Finally, I have to say that thanks to all the physicians you come here, it's not easy. I know that your time is very valuable, but it's still pay this time to come here. I'm very happy to say that. I'm a Chinese. This is the first time or second time to India, but the first time to Cochin to Kerala. But I say that so many good doctors. Hope in this afternoon you can enjoy. Hope I can know more and more people with you. So here that I want to thanks to some doctors. Maybe I cannot recite everyone's name, but I hope I can understand some of you. Dr. Sukesh from CMC Vellore. Dr. Anil Handoff from Max Birki. Dr. Riju from Believers Church. Thank you. Without Believers Church support, we cannot make such good event here. Dr. Apte, there are still, like Dr. George we just met, so many good doctors and so many good partners. Thanks to all of you. Okay, hope you can enjoy and have a good, prosperous today. Okay, thank you.
Thank you, Mr. Stephen, for your words, kind words. May I request, we have a very motivating talk for just 1 minute from our mentor, Dr. Anil Handu. He was not able to come here because of some reasons, and he has sent us a motivating video because he's been with us for our CUBE academic sessions, and he is very positive about the analyzer science. So we have a small short video of his. May I request Vaibhav to play the video of Dr. Anil Handu, please?
Well, good afternoon, ladies and gentlemen. It gives me immense pleasure to welcome you all for this session of Mind Manthan 2025. This program has been curated by Mindray India for enlightening us on various aspects of hematology analyzer science. I'm sure in the next few hours that this program has been designed, you guys are going to get a lot of great information from stalwarts in the field of hematology analysis. I wish I could have been there in person and wished you all and, at the same time shared my thoughts. However, due to my personal commitments, I'm not able to do that at this moment of time. But I really wish this program a grand success. And on behalf of Mindray India, I welcome you all once again for this program. Thank you for being here and have a wonderful day ahead, as well as a great session of academic learning. All the best.
Thank you, Dr. Handu. Although you are not with us, but you are always with us since you have taught us analyzer science. Thank you very much. May I request Mr. Joe, our Director Marketing, to please introduce what Mind Manthan is to us. Joe, please.
Hello. Am I audible? Thanks. Thank you, Shama, for that wonderful introduction. I think you got a little bit nervous. Definitely, I am also too nervous at this point of time. I don't know. This is a new concept which we are introducing to you. And my job today is to give you a clarity what we are planning and what we want to do. So, first of all, let me thank my teachers, my colleagues who all are here in big numbers to take out your precious time and to be with us and help us in doing this Mind Manthan. Now, can I have my first slide, please? Thank you. When we thought about an event, a lot of names came into the ideas. There was a lot of ideas coming into it. So somebody suggested, I think Vaibhav has suggested this name of Manthan. Then we dive deep into it. And when I was learning more about it, it's an incident which is described in Vishnu Puran, which has a lot of interesting aspects, characters into it. And what turned out to be only one product, there was multiple products coming out from this event. So Mind Manthan, for your small understanding, there was a small incident which happened, means once the Indra Deva was traveling and he met with Durvasav, who was in furious Saag. So Durvasav gave him an garland. With a lot of pride, he took that garland and he was supposed to wear it in his head. But unfortunately, the garland fell down and an elephant stood on it. And then Durvasa was so furious. Durvasa said, okay, I'm giving you a sharp that you will get aged and you will be going to have death. Indra got very upset. He said, give us some idea how we can improvise it. Then Durvasa said, you do Mind Manthan. Sorry, not Mind Manthan. Palari Manthan. I'm too much into Mind Manthan. Palari Manthanam. And get Amrit. If you have Amrit, you will be again young and energetic. So then there are two groups here you can see in the picture. One is the Devas and the other is the Asuras. So the Devas has to take the help of the Asuras to do this. Both are enemies, but in this contest, they have to come together. So if we are looking at this crowd, you can see two groups. One is the pathologists who are working in the lab, and the second, Asuras, who are coming to sell you something, right? So we are in different groups, but we have a common objective. And to get this common objective, we have to use our resources, our brain, and churn out the data which we are generating in our lab. Right now, the situation is that we are generating a lot of data in our lab. Are we able to use 10% of that data? Are we converting it into a sensible clinical utility data where we can influence the patient life? So Mind Manthan is all about that. We will be discussing how this data which has been generated by your symbol analyzer, any analyzer, can be utilized in a better way.
It's 2 o'clock.
To impact our patient life. That is the concept of Mind Manthan. Can I have the next slide? Yeah. So when in the initial events, we were talking about accuracy, brand value, precision, the TAT, things like that. That was our focus area when we were talking it. From there, we are moving little bit more closer to the reality, patient care. How we can do a better patient care, how we can improvise this patient care so that if a patient can go back to his home 5 minutes early, it makes difference. And that is where we are discussing and moving ahead. Right now, if you look at the structure of this event, we have a physician talking about what his pain areas are and a pathologist talking how he can support in a better way. So we will be keeping doing it. It's our first event. If there is any mistakes, kindly pardon us, but we will be improvising onto it and going ahead. Now, the biggest question will be why Mindray is so keen into it and why you have to consider Mindray. If you look, almost all the giants in the IVD industry are based in Europe or US, and their biggest market share is from Europe and America. Asian countries contribute to a big company's revenue is only 5%. So if any company has only 5% revenue, why should that company look into the problems of that particular continent or country? And Mindray, being an Asian country, understands Asia much better than any other multinational company like Roche, Smax, or Abbott. So we know this market. We know what cultural impact, what disease burden, what ethnicity diversity we have. We understand this much better than any of the IVD company. That's why Mindray, that question is significant for us. Now, Mindray has set up an ambitious vision for next 5 years. We want to change the way how our diagnoses are being done with the help of automation and AI. I would like to give you a small glimpse of a 1-minute video to showcase what is our vision for 2030. Can I have the video, please?
Sorry, due to some technical glitch.
I hope you had enjoyed this video. Thanking you all. And I wish we learned something new. You also learn and we also learn a lot of things and we try to implement in the future. Thank you.
Thank you, Joe, for all these insights. And it was a wonderful story. I think most of us know, but we have forgotten. So thank you for enlightening. Moving ahead with our academic sessions now, may I call on stage Dr. Rajalakshmi and the clinician from JSS. We are very thankful to Dr. Mahesh, Dr. Chepsi, Dr. Apte. They are really very busy people, but they have had time for our academic enlightenment for this analyzer science and how they tackle with these cases in day-to-day life. So they'll throw some light on that. Thank you. May I welcome Dr. Rajalakshmi on stage? And may I request Dr. George to chair the session, please? May I request you to please... Weber? इस पे CV लगाना है. CV. Yeah. May I request Dr. George to introduce our speakers for today, Dr. Rajalakshmi and Dr. Mahesh. So you will talk first and then Dr. Yeah, you can come in. You can come in. Yeah. No, it will be displayed.
I think I need not read it out. It's all already displayed in the screen. So let us move further to avoid losing time because we are going out of time. So people can read it. Okay. So this is the title she is going to present here.
Good afternoon, everyone. At the outset, I thank the team Mindray India for giving me this opportunity. Today, I am presenting a case of pancytopenia that was promptly managed in JSS Hospital. A 40-year-old male presented with history of 8 weeks, 8 days duration fever with generalized weakness. The patient had no history of nausea, vomiting, or pain abdomen. There were no bleeding symptoms on presentation. The physical examination of the patient showed pallor, patient was febrile, and on examination, there was no organomegaly. So for the clinician, the patient did not show any focus of infection. Baseline investigations were done, and the CBC results showed anemia with a markedly reduced hemoglobin concentration of 5.3 gram per deciliter. MCV was 97, MCH 34 picograms, MCHC 34.9, and total count and platelet count both were markedly reduced, and the differential count showed a relative lymphocyte predominance. So there was a case of pancytopenia. The other investigations which were done for the patient included procalcitonin, which was 0.06 nanogram per ml, and less than 0.1 ruled out a bacterial infection for the patient. The other investigations done were PT, APTT, fibrinogen, all three were normal. D-dimer was elevated. Serum iron profile, vitamin B12 and folate levels were normal as a part of anemia workup. And LDH, DCT, ICT all were negative, ruling out a hemolytic process. LFT and RFT were normal. So as a part of fever workup, serology for HIV, HBCG, HCV, EBV all were negative. Serology for dengue and Vidal negative. The tests were extended to wheel felix, scrub typhus, leptospira, again negative. ANA profile was negative. Then coming to the role of pathologist, there was a case of pancytopenia with markedly reduced total count, hemoglobin and platelet count. So we can see there is a relative lymphocyte predominance, 85.7% of lymphocytes. And the other abnormal parameter is 97.2 femtoliter MCV. Subsequent CBC results also showed markedly reduced total count. Peripheral smear examination showed scattered WBCs. They were very occasional in number with just 1 or 2 WBCs in 5 to 6 low power fields. So this case was challenging to decide whether the patient required bone marrow analysis, bone marrow examination to find out the cause for pancytopenia. The reason is the total count was very low. The WBCs were very less in number. The morphology identification was difficult. It was a difficult task. Another abnormal parameter here in this case was MCV, which was 97 or 98 femtoliters at different occasions, pointing towards a vitamin B12 deficiency anemia and related pancytopenia. However, the investigations, as I've already said, vitamin B12 and folate levels were normal. So I had to review all the peripheral smears again. So took all the peripheral smears which were sent for CBC analysis, and the smears were reviewed, taking more than 30 to 40 minutes. A careful examination of these mononuclear cells showed kind of binucleated, bilobed nucleus, large nucleus, and some of them showed clearly dusty granular cytoplasm, and these granules were obscuring the nucleocytoplasmic border. So I thought of neoplastic promyelocytes. The morphologic characteristics of these promyelocytes were compared with the scatter plot results, and this was the scatter plot that was obtained by Mindray analyzer. And we can see the circled area in red shows the cells population, which is showing high fluorescence, the granular promyelocytes. And on the other side, there is an illustration of a similar case of APML where the total count is more and there are more number of promyelocytes. However, the typical cells with or rods or faggot cells were absent in the present case. So peripheral smear diagnosis of pancytopenia with cells suspicious of neoplastic promyelocytes with a probable diagnosis of acute promyelocytic leukemia was given, and the patient was subjected to bone marrow study. So this was the bone marrow examination where we could see markedly reduced trilineage hematopoiesis, sheets of neoplastic promyelocytes. The cells were large, showed abnormal, dense azurophilic granules in the cytoplasm obscuring the nucleocytoplasmic border, and many of them showed bilobe nucleus which were seen in the peripheral smear. And this is another typical neoplastic promyelocyte with multiple or rods. The arrow is pointing towards a faggot cell. So we had multiple faggot cells for this patient. So the diagnosis was acute promyelocytic leukemia, and the biopsy again showed a completely packed marrow with sheets of neoplastic promyelocytes with dense eosinophilic cytoplasm, and the final diagnosis was acute promyelocytic leukemia, hypergranular variant. The case was referred to Dr. Mahesh Rajshekaraya for further management. So the key takeaway is a careful analysis of pancytopenia with hematology autoanalyzer results recommended a timely bone marrow study for the patient, which helped in arriving at an early diagnosis. And as we all know, early diagnosis of APML is very important and crucial to initiate therapy and to reduce the risk of mortality due to coagulopathy and DIC. A swift and simple, detailed peripheral smear examination is an invaluable tool alleviating the need for all other investigations to arrive at a specific diagnosis. So the present case underscores the importance of peripheral smear as an expeditious test, especially in cases of hematological emergencies such as APML. So a prompt management of case of APML by a clinician requires a collaborative effort by the pathologist, which can prove to be a synergistic model as in the present case between pathology and clinical hematology. I now take my pleasure to express our gratitude to Dr. Mahesh Rajshekhara, a renowned hemato-oncologist. He is readily available for any case discussions related to any diagnosis and always at the service of the patients. I welcome you, sir. I now leave the floor for him to present with the continuous case presentation.
Dr. George told me you give it to Dr. Sander because he's not. Sorry.
So, how many of you have handled the cases of pancytopenia? Almost everyone. And for every pancytopenia case, we definitely require a help of a pathologist. And why do we require a help of a pathologist? It may be a simple benign hematological disorders. It could be just a case of vitamin B12 deficiency or a folic acid deficiency, which are usually non-life threatening for the patient. That is one end of the spectrum. At the other end of a spectrum, you might be dealing with a very serious life-threatening disorder, just like this one, acute promyelocytic leukemia. And especially with the good machines like Mindray coming into picture, probably we will be able to identify this hypergranular promyelocytes early, making the diagnosis very quick. And it can be sometimes life-saving for the patient because the patients with AML M3, it is 100%, almost like more than, Dr. Shishepti knows this quite well, it is almost like more than 90% curable in many of our patients because many of them patients are in low risk. But at the same time, even if there is a delay of 1 day, a patient can, especially if the patient is in DIC, they can come with severe intracranial bleed. We have lost some of these patients because there has been a diagnostic delay, and because of that, either a patient has landed up in a severe neutropenic sepsis because, as you can see here, this patient white cell count is hardly like less than 1,000, and the absolute neutrophil count is even more less. And these kind of patients, the diagnosis has to be very early and it has to be very definitive so that the patient, we could opt some life-saving measures. We can immediately start them on a life-saving treatment in the form of arsenic and atra, which can save the life of these patients and reverse the whole process of malignancy as well as DIC in this kind of patients. Now, everybody knows the diagnosis of pancytopenia, especially the pathologists here. Whenever you are subjected to a patient with having a low hemoglobin, low white cell and low platelet count, you term it as pancytopenia. And this is how the clinicians classify pancytopenia. Either they have this pancytopenia from birth due to some congenital anomalies, which we call it as inherited pancytopenias, like Fanconi's anemia, wherein you see some muscular and skeletal abnormalities. And of course, many of our patients, especially the pediatric as well as adult patients, have causes due to acquired reasons. It could be a simple B12 deficiency. It could be some infections. Very often you may see dengue, other viral infections, EBV infections, or else it could be just a big spleen causing hypersplenism, again causing a pancytopenia. Now, these are the various causes, and the most important cause, all the pathologists know it, is megaloblastic anemia, wherein they are deficient in either B12, folic acid, either as a part of nutritional deficiency or because of some drugs, or it could be an autoimmune phenomenon causing pernicious anemia. And megaloblastic anemia is the most common cause of pancytopenia in India. And of course, second comes infections. We see a lot of infections. And of course, these automated machines especially can identify these reactive lymphocytes in the peripheral blood smear, which may tell us that these particular patients might be having a viral infection as a cause of pancytopenia. As you can see here, it could be bone marrow failure, which could be causing pancytopenia, myelodysplastic syndromes, which could be causing pancytopenia. It could be increased hematopoietic cell production because of sepsis, hemophagocytosis, and various other causes. All can lead to pancytopenia. And of course, as I told you, inherited. How do pathologists classify pancytopenia? For pathologists, it all depends on how the marrow is looking. If the marrow is hypocellular, you label it as hypocellular marrow with pancytopenia, and the causes are usually a bone marrow failure syndromes. Second, the cellular bone marrow, as you can see here, the cellular hypercellular bone marrow, and very often hypercellular bone marrow with pancytopenia is usually due to hematological malignancies or infections, or maybe a peripheral destruction, which could be again because of infection or autoimmune phenomenon. This picture you usually see in aplastic anemias, and this picture you usually see in leukemia. So this is how the pathologist classifies the cases of pancytopenia. Either it is a hypocellular marrow causing pancytopenia, hypercellular marrow with pancytopenia, or a normocellular marrow with pancytopenia. And these are the ways by which, and as I can see here, the most common cause of pancytopenia in India is megaloblastic anemia. The other causes are infections, malignancies, drug toxicities. All this come into a picture while you are evaluating a cause of pancytopenia in your hospital. So you may have to think of varied diagnosis when you are approaching a patient with pancytopenia, especially in our case, wherein the patient presented with fever and pancytopenia. There could be wide array of differential diagnosis. It could be nutritional, it could be an infection, it could be a drug toxicity. Maybe, who knows, he might be on some Ayurvedic, homeopathic, or other antiepileptic preparations, antipsychotic preparations, which could have caused pancytopenia. And finally, not to forget, severe conditions wherein patient can lose life, like HLH or hematological neoplasms. So this is our usual approach. This is a clinico-pathological approach for most of the patients with pancytopenia, wherein the first step is a CBC, rule out drugs and toxicities, toxins, which are very important. Then very important is you need to run a machine under a good CBC machines, which will tell us, which may give us a clue whether the patient is having a hematological neoplasm. Peripheral smear is very important. We need to do a wide array of biochemical and infectious workup, starting from B12 deficiency, lead levels, copper levels, serologies. HIV is very important. All patients with pancytopenia, unexplained pancytopenia, you should always take into consideration whether the patient is having a retroviral disease, or else the patient might be having other infections which you need to rule out while you are evaluating the cases of pancytopenia. And once you have done this, usually you land up classifying it as either a consumption problem or a production problem or a peripheral destruction problem, thereby helping us in making a proper diagnosis. So we have to go in a stepwise manner. You have to take a detailed history. Physical examination is very important, because if a patient has significant lymphadenopathy, you know for sure that this particular patient is going to have hematological neoplasm as a cause of pancytopenia, and thereby ordering the pathologist to do either a FNAC or take a biopsy from the lymph nodes. Laboratory investigations, and finally some specific investigations will definitely help a clinician in making a diagnosis of pancytopenia. You can see here the duration of symptoms, the family history, the age of the patient. All these are very important and play a clear role in identifying the cause of pancytopenia. Drug intake, history of drug intake has to be taken, because many of the drugs which we use in routine practice can cause pancytopenia. And of course, a detailed clinical examination plays a very crucial role. And of course, this is supplemented by various lab investigations. As you can see here, the reticulocyte count, reticulocyte production index, LDH, LFTs are very important, because very often patient might be having hepatitis with pancytopenia, leading to a diagnosis of hemophagocytic lymphohistiocytosis. And after ordering and getting all the information from the basic lab investigations, we always clearly look at a diagnosis based on the peripheral smear. So what's the diagnosis here? Pancytopenia with this peripheral blood smear finding? Megaloblastic anemia, isn't it? You can see hypersegmented neutrophils. What is the diagnosis here? Pancytopenia with this kind of blood picture? There is a myeloinfiltrative process. You can see that there are teardrop cells and nucleated orbices. What's the diagnosis here? AML. You can see the clear, long, slender or rods, blasts. AML is a diagnosis, and AML might be causing the pancytopenia. What's the diagnosis here? Patient is having pancytopenia, and just looking at one cell, you are able to clearly say that this particular patient might be having this particular diagnosis, and based on that, you order bone marrow and other findings. MDS, because he has a pseudo Pelgar-Hute anomalies. What is the diagnosis here? Patient, young male coming with fever, few cervical lymph nodes, peripheral smear will give you a diagnosis. Infectious mononucleosis. You can see the reactive lymphocytes. What's the diagnosis here? A patient coming with pancytopenia and few cluster of cells. Very often we see prostatic cancer presenting with severe pancytopenia. So this was a classical case of a prostatic cancer. Hence, the pathologists play a crucial role in evaluating a cause of pancytopenia. 90% of the work is done by the pathologist and 10% of the work is done by the hematologist. So based on that, you of course order for the specific test. In our patient, what we did was we did a flow cytometry, and that confirmed the diagnosis of APML, and again supplemented by doing more confirmatory tests like molecular studies. FISH for PML RARA and PCR for PML RARA was positive, confirming a diagnosis of AML M3. Patient was started on Lococo protocol. That's a combination of arsenic and atra, which most of the hematologists in India use for the treatment of APML. Now the patient is in remission, starting from a point wherein a patient had a life-threatening disease where we could have lost the life of the patient. We are now able to say that patient is virtually cured of the disease just by making a prompt diagnosis. Very few cells, and still the good peripheral smear, you were able to identify the abnormal promyelocytes, and based on that, guiding a hematologist to order for more specific investigations like flow cytometry and PML RARA. And with that, we started a patient on the protocol, and hence we are able to cure these kind of patients very often without a prompt diagnosis. Of course, there are other end of a spectrum. We don't have a diagnosis and we have lost APMLs, and later on, retrospectively, after the patient had IC bleed, we have made a diagnosis of APML, especially in a patient with pancytopenia. These things could also happen, but with newer advances, newer technologies, maybe we will be able to identify these kind of life-threatening disorders much earlier and be able to start the treatment much earlier. Thank you.
Thank you, Dr. Mahesh, and thank you, Dr. Rajalakshmi. There are a few questions online, but may I request the forum is open for Q&A now. Any questions?
Sir, not regarding this question.
Yeah.
Post-chemo patients, usually they will present with a marked leukopenia. We have an issue with the TLC. Sometimes, the patient, as an oncologist, they will start with the GCSF therapy. One day the count will be like 100. Next day it will be again, it will fall. We'll get immediately call from the clinician that we have started like a GCSF therapy, but the count is, some day it is increasing trend, some day it is decreasing trend. Do you have any challenges like that in your hospitals?
Yeah, so post-chemotherapy pancytopenia is a pretty much well-known entity. And based on the intensity of a chemotherapy, sometimes it may take a huge time. Sometimes it may take up to 3 to 4 weeks also, sometimes for the counts to
My
recover.
doubt is it related to as a patient or it is a due to technical aspect, like
So
a
there
cool
could
term.
be a lot of pharmacokinetics as well as pharmacodynamics, and of course the genetic factors involved in what could be the extent of pancytopenia in a given patient. Say for example, you have started a patient on 6-MP or methotrexate. There could be certain mutations which we usually tend to order, especially for patients who are on 6-MP, just to see how sensitive the patient is. Based on that, we also titrate the dose of a 6-MP. And similarly, it holds good for other chemotherapeutic agents as well. Some patients are usually more sensitive for chemotherapy based on the genetic abnormalities they have, especially the P53 mutations and all. They are more sensitive for the chemotherapy and toxicity.
Just want to clarification from the ma'am that do you have any challenge in your lab, like regarding this same TLC? For even the instrument has a LOD like in 100 cells, sometimes the count will be lesser than LOD. So usually instrument will do the dilution and then it will give the value. But the clinician may not happy with that values because they started the therapy, the count someday it will be increasing, someday it will getting fluctuated. And how do you, rectify those issues in your?
In our lab, okay, we have automated analyzers, both Mindray and Sysmex Expert XN1000.
Yes.
So we have another measure, that is delta check, available in our instrument.
Yes, ma'am.
And we usually collect for all critical values. We have the clinical history available with us. So whenever we come to know the patient is on chemotherapy, we serially continuously monitor all the WBC counts. So we will know this is a patient of chemotherapy who is receiving treatment. So that is the reason. So we keep looking at, we keep a track of these WBC counts and we manually verify all the WBC counts. So it is documented. We are not facing any issues as such.
Thank you. Sure.
If I understand your question, you want to be interested, what is the variation in WBC count? Say, suppose it is 80 one day, it is next day 160. Is that your question?
Yes. The clinician will start.
Sure. Sure. Here, I think it's a fault of a clinician. For me, 100, 200, 300 is the same count. If 0 count or 80 count becomes 500, I think the marrow is recovering. If the next day count goes to 800, I think the marrow is recovering, and a day after it would be in the range of 1500. You may go to 500, next day you can be 300, but clinically it doesn't matter. You just said that you will be manually doing the counts. If I have a history that I have done an allograft, I have given intensive myeloablative therapy, day 10, count is 10. I'm not worried. It is bound to be 10. So we have to optimize our resources.
Starting the GCSF therapy, after starting usually the counts tend to rise. The clinician may expect to be increasing a trend. So someday we'll get again lower counts. Like one day it will be 700, 800, 100, it will be 100, 200. So instrument will have an LOD. So if it is even lesser than that LOD also, if the count is low, how the instrument will underestimate the WBC count? That is my question.
It doesn't matter, to tell you honestly. Suppose I have given 7-3 kind of an intense protocol where I'm anticipating neutropenia for 21, 22 days. On day 12, day 13, I will not start jumping in my chair. Because you must anticipate what duration of neutropenia you're going to have. That is very critical. Yes, suppose I have given a protocol like RCHOP. Day 7, WBC goes to 500. Now it is day 20. If the WBC is 500, I would worry. Or as Dr. Mahesh said, like 6-MP methotrexate, if there is a mutation in TPMT or NTHFR, you can have various ranges of neutropenia. So neutropenia, I feel, we look at it this way. What is the anticipated duration? As Dr. Mahesh said, what is the initial intensity of the chemotherapy? That things matter. And 1 or 2 days here and there, I don't think it matters at all.
Hello. Dr. Raj. Thank you. Just one observation that pancytopenia is a dangerous condition. the value of the peripheral smear is just invaluable in every case of pancytopenia. And the quality of the smear is what determines what the pathologist sees. Pathologists may be very good, but if the quality of the smear is poor, the result will be to look at the smear again and again. Excess EDTA is the biggest culprit in all this. So it's always better in such situations to get a fresh smear and send whatever way, even if it is not a tongue-shaped smear. You can get a fresh smear from the handprick, send it to a pathologist. That will definitely identify, any ordinary pathologist will definitely identify these cells. This is the first take-home point for me. Second one is, we all used to resort to something called myeloperoxidase stain. Now it is unheard of because of two reasons. One, whatever we are getting as myeloperoxidase staining in the proprietary market is absolute rubbish. It doesn't stain at all. Our alternative of going back to benzidine is impossible because benzidine is now banned. So now myeloperoxidase is out of the armory of the pathologist, and we have to find out some technological solution by which we should be able to identify the peroxidase positive cells. Is my request, because now benzidine is banned, you don't get benzidine. So I am finding it very difficult as a pathologist to not to have peroxidase. And lastly, what Dr. Mahesh has very clearly said, the pancytopenia with a normal marrow. This is what now the most common kind of, what I see basically is this picture, and we are stunned. Where the cells have disappeared and marrow looks perfectly normal. And often we run into, as doctors pointed out, unknown infections, or we treat the patient very empirically and they suddenly improve from that unknown infection, we don't know. So an intensive search for infectious agents is, I think, mandatory in every pancytopenia case. These are my my observations from my experience. I request my Guru Joyce to share his experience, because he is a hematologist over 45 years and knows all the basics.
I don't have anything to contribute as such, but as Dr. Rajalakshmi rightly pointed out, one of the things which every pathologist should be conscious of is that when you have a pancytopenia, APML is one of the differential diagnoses. That high index of suspicion is absolutely essential, which possibly would have saved Dr. Rajalakshmi the difficulty in looking at for several times. Probably this could have been picked up in the first thing itself. Unfortunately, this is not true. But for the pathologist here, I would suggest that APML is not such an uncommon condition in a referred hospital. So it is very important to have the differential diagnosis in the list. Because if you don't have it, you may miss it. Because it's notorious to be presenting with pancytopenia. Thank you.
Yes, sir. Actually, as you said, initially the samples were coming only for CBC results. It was actually, I was posted in a different section. So when I came to see the smear, there were already 3 more smears. So I took all the smears and reviewed for the first time, because those smears, the cells were overlooked. Assuming the case is pancytopenia, probably B12 deficiency, because MCV was high. So I saw the slide for the first time.
No, I was just mentioning a practical point.
Yes, sir.
Just point that is you have to keep in mind.
Yes, sir.
The junior most pathologist also, if he or she can keep this as a differential diagnosis in the outside of our mind, you will definitely pick it up if it is there.
Yes,
This
sir.
is my personal experience.
Yes, sir.
Hello, ma'am.
Dr. Shashi, sir.
Some of the machines do have a peroxidase channel. Like you have a peroxidase channel and a basophil channel, you can have, and machine can tell you whether the cell is peroxidase positive or a cell is peroxidase negative.
So is it possible to miss APML? Sometimes it has happened to me in my own experience. A patient had a cells of only 200, 300. And I clearly searched for abnormal promyelocytes. I couldn't find one, maybe because of the time constraints. I'm not sure. We did a bone marrow aspiration biopsy. It was a very difficult aspirate. It was a fibrotic marrow. It was a totally fibrotic marrow. I still suspected a malignancy and I sent it for immunohistochemistry. And immunohistochemistry said that there are immature forms and we may consider a diagnosis of hypocellular marrow. I just kept a patient under close observation because I was pretty much sure that this was not going to be aplastic anemia, and with just a supportive treatment. On PT, APTT, other basic workup was normal, and I had no suspicion that this was APML, so I did not run a PML RARA because there were no abnormal promyelocytes which I saw. Patient did not have fever. Patient was otherwise very stable. For almost like 3 to 6 months, I was following up the patient, and patient was absolutely stable. And finally, one day, patient came to me with a white cell count of 5,000, which was 200 to 300 to start with. Now it is 5,000. Wait, let me have a look at a smear. When I looked at a smear, there were abnormal promyelocytes. And now you have a clear-cut diagnosis. I had already counseled the patient for aplastic anemia treatment. They were about to go for a transplant. And finally, one fine day, she came with increasing white cell count, peripheral smear showing abnormal promyelocytes, and PML-RAR alpha coming positive at that point. Yes. Yeah.
No, but APML will not go like this for 6 months. It must be MDS APML.
No, possible, but I had...
MDS evolving into APML.
Yes. Sir.
Because CA breast patients, when treated with anthracycline,
Yes.
they have a higher incidence of APML over a period of time.
Possible.
Therapy-related AML.
But this was not the first patient, sir. I had 3 or 4 such patients wherein the history was very chronic, almost like going on for 1 year.
Very unusual.
Yes.
Very, very.
Sir, thanks to Mahesh sir and Rajlakshmi ma'am. I'm from JSS, and from my PG to being a consultant now, I've seen a lot of changes, sir. Adding to the quality of the smear, it also depends upon how trained you are to see the smear. Because I missed a lot of cases in my residency. Now I'm confident to tell my residents not to miss some cases, especially in APML, sir. Many cases are often picked up in the night duties by my residents, which are confirmed by myself in the morning. And that gives me confidence and happiness that people are actually paying more focus. Residents are learning, and it gives us more happiness when we are conveying to the clinician that this is APML. And one more thing I would like to point out, sir, especially when sir was talking about pancytopenias post-chemotherapy, in my cancer hospital, the day 8 blast count, especially in ALLs and pediatric ALLs, becomes very easy. Because when my resident gives a day 8 blast count of 20% and I do the DC, it will be around 10%. So that variation, that gap should be conveyed to the clinician properly so that the baby gets adequate chemotherapy, not higher doses or lower doses. And who is doing the marrow? I see many of the times that suppose the resident or the junior consultant is finding difficulty in getting an aspirate, the senior consultant usually helps and they might get a better yield. That also plays a major role, especially in CMLs where there is a dry tap and necrotic marrow, especially in ALLs when there is a dry tap. So my seniors have helped me luckily, and I'm grateful to them that things are not getting missed. Thank you.
Thank you, doctor. Sugesh. Now, thing is, if you have a pancytopenia and you're strongly suspecting, you can do an extended white cell count where the machines are capable of doing that. Some of the machines, not all of them. So I think you should look at that option. Now, we are talking about where you are not able to find a promyelocyte, but there are APMLs where you can see a abnormal cell in the peripheral smear, but you're not sure whether it is a promyelocyte. It could be an acute myeloid leukemia,
It could be, in fact, one of the differential diagnosis for APML is monoblastic leukemia. So what I do is, I know that APML is associated with coagulopathy. So I always look at, there is a APML marker for coagulopathy. You know what is it? Very simple. Slightly abnormal prothrombin time and shortened APTT. You can be confident to say APML, and when you find a blast like that, I have made a lot of diagnosis and 100% I have been on spot on, just looking at the coagulation parameters. When the morphology is confusing. Yeah, that's also there.
Other thing, Sukesh knows that in our institute, we always run our marrows through the machine.
Yes.
And we call it as something called a beamogram.
Huh.
So if you have a high count in the marrow, it is not
True.
aplastic.
Yeah.
Aplastic gets ruled out. And on the machine, you can pick up the promyelocytes straight away.
Correct.
In the bone marrow.
This was a hard aspirate because I myself tried the aspirate and hardly any particles there.
Thank you. May I conclude this session by saying that I have attended all the cube, no? But the difference with Mind Manthan is clear that now that the clinicians have come to discuss the cases, the discussion is at a different level. And I think the trend continues. Thank you all for a nice discussion.
Thank you very much. May I request Dr. Sankar please come on the stage to felicitate our speakers. May I request Dr. Rajalakshmi to please come on stage. Thank you very much, Dr. Sankar, and both the speakers. It was really very enlightening. May I request our next speakers for the day, the duo of Dr. Boni and Dr. Chepsi. So, may I request Dr. Chepsi to please come on stage? And may I request Dr. Sankar to introduce our speaker?
Dr. Chepsi C. Philip, he is professor of clinical hematology, as you can see, and he works, both of them work in Believers Church Medical College Hospital, one of the foremost hospitals as far as hematology is concerned in the middle part of Kerala. I welcome, you can see his degrees, he's a very good accomplished hematologist. Even I report his bone marrow, so I know how good the marrows are. I request him to present the topic, missed or masked or misdiagnosed clinical challenges in myelodysplastic neoplasm. So the new word neoplasm has come back here. We were talking of syndromes in the last session even because habits die hard. We had to talk on myelodysplastic neoplasms. Well thought out topic. Welcome both of you to discuss the case. Thank you.
Thank you, sir, for the kind introduction. I acknowledge the presence of my teacher, Dr. Sukesh, is sitting here. Dr. Sashi is the one who has been my examiner for the DM. So if I make any mistakes, you have to blame both of them for whatever I do. So can I have the slides, please? So I think, yes, old habits die very hard. So it is going to come out as myelodysplastic syndrome only from my mouth also, even though while typing it, you have the freedom to think and then type it. But it's still attributed as MDS itself. So we'll stick to that. So see, like my previous speakers, the group of speakers had already described how pancytopenia is approached by the pathologist, by the clinician. So primarily, most of the times what we do is we wait for the colleague in pathology to tell us if it is cellular, acellular, hypocellular, and that gives us a direction. Because in this day and time, nobody is going to wait for us for a week to say, okay, I've done the marrow, come back after a week, and now this is your diagnosis and start the treatment. Everybody is very anxious, and particularly doing a bone marrow in at least most of the people connect a bone marrow to a malignant etiology. That is ingrained in our society that if you've done a marrow, most likely they're suspecting a malignancy. And the more you sit on it without giving him an answer what it is very distressing. And it is very difficult to handle that distress in the clinic. It's very difficult. So I'm going to present some challenges. I don't have the answer to it. I'm just showing what we as a team have thought this could be, but we are open to suggestions. So if everything goes right, now MDS or MDN, we are now recognizing now every year our understanding is changing and changing. Now initially, at least during the initial part of my training, it was clear cut different diseases. Aplastic is different, MDS is different, AML is different, but now that boundaries are getting blurred. Now we are still recognizing probably it is likely an immune mechanism which connects each of it, and we don't know whether they are different diseases or they are continuum of the same disease. But even now, our therapeutic standpoint wise, we differentiate between them. I'm sure in the next coming years, as our knowledge evolves, even our therapies might change as we understand it. So currently, we recognize that potentially there is this initial event of clonal hematopoiesis of indeterminate potential that occurs, which is an acquired somatic mutation, which occurs likely as we age or as an influence of insults in the environment that we have acquired. Initially, the chip usually doesn't present with a cytopenia. It is likely to be only an acquired mutation. That is something that we have understood when we have screened populations for mutations and understand that there are certain mutations that exist which likely can evolve into cytopenia in the future. So chip is what we think is the precursor event, and then cytopenias develop, but still you might not have florid dysplasias. Then we call them cytopenia of undetermined significance. But when you have what we understand as dysplasia, abnormal forms, once that occurs, we label them as MDS. And as the blasts increase, then it evolves into AML. So we now recognize, CHIP and CCUS was not words that we knew 10 years back, but now these are very, very commonly reported when we, like I think somebody had earlier mentioned, you have this normal marrows, cytopenia. Maybe this might be an answer. It could be a CCUS at that time, but we need tools to find out what they are. But these are very relevant problems in the clinic because most of the time they would come with a cytopenia. We'll end up doing a marrow. Nothing is clear on the marrow. It's very difficult to say that you are okay, but your reports are not okay. It's very, very difficult. So recently I had this opportunity to reflect on World Blood Cancer Day, which was on the 28th. And I was trying to find out the stats. So ideally, it is reported in the West that as you age, beyond 65 years of age, the incidence is 70 per 1 lakh. That's a very high incidence. But we are not reporting that. We are not getting that kind of value. Now, it can't be that we are not able to recognize it because most of the centers, at least we have very skilled experts sitting there who will identify dysplasia. It can't be missed. So there's something that I don't know what is happening. It is different, and we don't have good data from India either. So this is a global description of the incidences. And if you can see those yellow areas, those are areas from where we have not yet reported. And even if we have reported, it is going to be much lower than what is reported here. So you can see this is the entire population, not more than 65. More than 65, it is reported as high as 70, whereas 12.6 to 15 in most developed countries, it has been reported as. Now, what can be the reason for it is probably the same fact that these are diseases which are a continuum of each other, and probably it is difficult to demarcate each of them and put them into boxes. So for that reason, it might be left as descriptive entities, and the name MDS might not be revealed in the diagnosis. So it is very likely these are the challenges that the reporting is not occurring, but all experts are here and we will be happy to hear from your experience. So these are tables that we all recognize now of the differences between aplastic, MDS, PNH. They're all, we now recognize, are going to be a continuum. At least the germline mutation part of it we recognize are a continuum, but the somatic part we are still understanding what is happening. But there are some clues which we can now help us in terms of additional investigations, which can tell us key whether this is aplastic or whether this is hypoplastic MDS. Like initially, we had a teaching not to do marrow for, sorry, not to send a cytogenetics for aplastic, but now we recognize even in aplastic, you can have cytogenetic abnormalities. Those are the common cytogenetic abnormalities that you see in aplastic versus the ones that you see in MDS. So that is one clue. If you have this hypocellular hypoplastic MDS, you have a cytogenetics, it can give you a direction as to what kind of disease it could be. This is the entire spectrum. I'm not getting into it, but you can see the overlap across, even amongst the genetic markers, you can see the overlap that is occurring in all these diseases. So the bottom line is there is a stem cell defect. Now, what comes first, when the next hit occurs, all this we will eventually understand. And finally, probably there'll come a day where these might tell you which direction it is going for us to choose therapies. So if everything is clear, this is our approach. So you have a blood cytopenia. You ideally will do a rule out all the causes, as Dr. Mahesh has already asked or discussed, which could potentially cause cytopenias. If you have ruled them out and you don't have any clue from the history, what is the cause of the cytopenia, we almost always will do a marrow to find out the cause of the cytopenia. And with the marrow, we do the regular morphology, and also we send for additional tests like karyotyping. Now we have the tool of sending NGS samples also with the, you can send it from peripheral blood also, but at our center, our practice is doing it with the marrow. And currently, as of today, at least the WHO 5 has labeled MDS in terms of morphology or just chromosomal abnormalities. Currently, that is the way they've easily differentiated it. So I think this is the previous classification, but now you have this increased blast, low blast, and you have MDS with ring sideroblast or SRS2 mutations or TP53 or deletion 5q. This is, in a nutshell, the clear-cut MDS findings. These are easy to identify. Most of the time, we won't make a mistake in identifying this. You will get the cytogenetic abnormalities, which will tell you whether this is deletion 5q. Your NGS will give you an idea whether there's SRS2 or a TP53. All those are clear. The problem happens when you have this not more than 10% dysplasia reported, but there is a hypocellular marrow. That is a confusion. So that is where the CCUS, ICUS, or the chip, all this might be normal conversations that we should have with our patients. If everything is fit, we slot them into one of those categories. You have risk calculators which tell them whether it is low risk or high risk. Only curative treatment for an MDS is going to be a bone marrow transplant. If it is high risk, if he is young and fit, that is what we offer. If it is low risk, or if he is younger and we anticipate that he is going to develop a leukemia, then we usually offer them hypomethylating agents, or it is supportive care. So having MDS, it's clear cut, is very easy to treat and to diagnose. But I just want to highlight the problems that we have in it. So this is the ASH cartoon of how MDS is diagnosed in the West. So you have the same thing. Almost here also there's the same thing that we do. Plus or minus, most centers, many centers might not have access to NGS, but that is a test which is easily outsourced. And I think it is a common practice amongst all hematologists to order for an NGS in most of the marrows. So these are the routine tests that we do. All these tests, ideally, if all comes positive, you know it is MDS. But I don't want to waste my time on talking on MDS. These are the tests that Bonnie will, I will talk to Bonnie and just get an idea, oh, cellularity, monocytes, all that. It will give us some direction where to go. But that is when it is all clear. If it is clear, it is so easy to slot things. MDS is very easy to slot things. So morphologically, if you have fibrosis or a hypocellular marrow, you know which slot it is going. Given the fact that you have a dysplasia more than 10% in at least one lineage. So given that occurs. Or if you don't have that, if you have a TP53 or deletion 5q or SF, sorry, I think I mentioned SRSF2, it is SF3B1 as a mutation. So this is clear cut. I think going forward, and that is what the authors here also have alluded to, that we will probably come to, depending on the resources that you have, you'll either slot them into a genetic kind of scoring or a morphological kind of scoring to guide your treatment. So that probably will evolve as we go ahead. So that is the kind of treatment that we do. Now I'll just discuss real world problems that we have. Now this is a gentleman, 76-year-old, has a little bit of comorbidities. He came to us in 2022 with an abnormal pain, went to orthopedics. Most routinely done test is always a CBC. In the CBC, a pancytopenia was identified. He had bony pain that time. That's how he came to us. And initially, we thought because of the bony pains and the cytopenia, it is most likely to be a leukemia. But to answer the question, we definitely did a marrow. And in that marrow, these are the initial findings that we found in 2022. This is at the first time when he came to us. So here again, this is a very descriptive marrow. Dysplasia was not good enough to call beyond 10%. So that MDS diagnosis, this is real world. This is how many times we get that report. But the clue, or at least one direction that we have, is the cellular marrow. So if it was a cellular marrow, clinically what we think is either there is intramedullary destruction or there's a peripheral destruction. So either it is going to be MDS or it's going to be immune. That's very simplistically speaking, but that is our initial thought process. But considering the age, we always think that it is likely to be an intramedullary process, elderly male, very likely, less likely to be an immune process. So these are all clinical cues that we get. But we don't, so the patient is looking at you anxiously. I have a cytopenia, I've done the marrow, what is the answer? Now, it is very difficult to tell them that there's no problem in your marrow. Because then the understanding is that, okay, this guy doesn't know how to diagnose my disease. Then the problem is he will go on a hunt. He will go all around the world and I don't know, he'll get lost somewhere and that's the end of it. So it's very, I don't know, it's a challenge to talk to these patients and win their confidence and accept the fact that, sorry, at this point in time, this is what your marrow is. Wherever you go, this is what is going to be reported. Nothing more you can do in it, but you have to give them, somehow you have to win their trust. So that is a bit challenging, at least at the areas that I work. Trust might not be that good. But so assuming this is it, we had a discussion and we told it could be MDS low risk. Now, because you're troubled with this, I'm not going to treat you, but I can offer you supportive care. We can give you growth factors and see how it goes. So that's what we started in May 2022. And yeah, so there was always the suspicion whether I'm doing the right thing or not right thing. And unfortunately, by August, he ends up having a pneumonia with a pleural effusion, becomes sick, get admitted. So it is the understanding of the patient that if somebody has treated, you have to get cured. Otherwise, there's something wrong in what you have done. So because he became sicker, he rightfully took another opinion. And thankfully, he traveled to Vellore. And there, all these reports were repeated. And in there, also the description was very similar. But it was given a label of MDS low risk at that time and initiated on lenalidomide. So I think there was a molecular data there that time, but probably it was not given to the patient. That must have influenced that decision. But surprisingly, with the lenalidomide, the patient's counts did improve. So it improved for a while on lenalidomide. They stopped the GCSF and the L-Trombopac. And for, I think, close to 5-6 months, he remained all right with that. But in another 5-6 months, what happened is count again started dropping down, and this time we didn't have a clue. So MDS progression we didn't feel because there are no blasts in the peripheral blood. The cytopenia is not worse than the first time. So we assumed it could be due to the drug itself. So why not stop the drug and see? So this time we stopped the drug, and that 22 and all, I think, was peak COVID time. He didn't travel anywhere else. He stuck with us, and we stopped the LEN. And with that also counts then improved a bit. But what differently that we did that time was we sent for NGS. NGS was not in a normal armamentarium initially. So because it was unexplained, we had sent an NGS, and I think the NGS had shown an SRS CEF2 mutation. Now, that is not diagnostic, but at least it is, I think it is giving us some direction that this could be evolving MDS. It could be a CCUS which is evolving, or at least there's something I can tell the patient that, see, the marrow is not normal. You have a potential to transform to a malignancy. Then I say MDS as malignancy for sure, and it can evolve into AML. So you're on the right track, but the treatment is not benefiting. Now we can change treatment. Then we again went back to GCSF and Eltrombopac, but this time somehow the counts really improved, became normal. But from that August time to October, what happened is then he got admitted with the CNS complication. He had multiple infarcts. That eventually led to his fatal outcome at the end. But from 22 to 24, till we had this doubt of what to say, patient has to live with this anxiety of, I don't know what these guys are doing. I don't know what my disease is. I've done a marrow, so it is a leukemia, and he's not telling me it is leukemia. They live in that constant fear, which is not something that we really want to convey to the patient. So I think we, other than our expertise, sometimes when we miss diagnosis or when we are unable to get the diagnosis, if we don't have the expertise more, this is one tool that we've relied on to give us a direction. If there are clonal markers there, we can confidently, assuredly tell them that this is probably one of these entities and it is in a continuum and we're treating you as low risk. So this was one case. Yeah. So this was the mutations that had come that time. Similarly, another lady, she also came with some other problem, identified with cytopenia and referred to us. And initially we did the marrow, again, the same kind of description, mildly hypocellular, mild dyspoiesis, and we don't know. And we did a West that time. By the time we had become a little more alert as to doing it, but initially we did the West that time and no variants were identified. So the West is a readout. So many times they might not be in tune with what you want. It's a readout. They will just give you the readout. There'll be some variants which are classified as variants of uncertain significance, and some pathogenic variants. So if you say that I'm looking for MDS, only they will look at pathogenic variants which got MDS present, not present. Sometimes there'll be variants of uncertain significance also, which are known to be precursor lesions in AML or MDS. So for this lady also, we did the marrow. I think twice we did the marrow when we didn't have an answer. There was no dysplasia reported. And that time, because we thought immune mechanism is one, we did the autoimmune profile. That was very strongly positive. Tried her on steroids, but the cytopenia didn't improve. When she had some other skin lesions, all that improved, but cytopenia remained the same. Then she came to us very recently, again with a febrile neutropenia now. And now when we saw there are some atypical cells on the peripheral smear, we did a flow, repeated the marrow, and now there were blasts, and then it had transformed not transformed to acute leukemia, but it is MDS with excess blast, we feel. But still, I think there is no dyspoiesis greater than 10%, but then blasts have come in. And because that lineage switch was present in the flow, we have labeled it as MDS. And we've offered us as a cytidine for now. But this is again a problem because the autoimmune markers came in. We went in that direction for a while. And then only when she came back with a cytopenia with blasts, we recognized that this is likely MDS, which is evolving into AML. Here again, when we went back to the NGS findings, we recognized that there was a DNMT3A mutation, which was there in the VUS. Which could have been a potential trigger for us to think earlier itself that this could have been MDS. Not that we would have made any change in treatment because it was low risk even then, but we could have given some direction to the family. This is another lady which we recently had to proceed with a transplant, a lady with 19-year-old girl with aplastic anemia, diagnosed elsewhere across Kerala from 2020 to 24. Menorrhagia at the age of 14, thrombocytopenia seen then, marrow done elsewhere, labeled as aplastic anemia, tried some Ayurvedic medicine, then switched to cyclosporin and L-Trombopac, had a documented response. Her menorrhagia had settled. It was not complete hematological response, but she was transfusion independent with this treatment. So she likely must have had the aplastic kind of presentation then. But then when she came to us, the thrombocytopenia had worsened. It was 2 years off her last treatment, and now she had come with a full-blown cytopenia. So this time we went ahead and did the marrow again at our place. So here now dysplasia was reported with blasts in the morphology. And so at least there was this poiesis there. But West and cytogenic did not show anything. So this is a girl probably in that continuum of aplastic anemia, PNH, MDS, who must have been identified at different time points at different centers. But eventually, because it had progressed, we ended up transplanting her, and she just got discharged yesterday with the same. So I'm just highlighting the challenges. Everything is never clear. The difficult ones, we are always in a muddle, and the patient is even more in a difficult situation at that point. And I would invite
Dr. Chepsi, I think we are running short of time a little bit. If you could
I think
conclude.
I'm done with it. Yeah.
Yeah,
So
fine.
these are the
Thank
cases.
you.
Yeah.
Thank you. I think we should go to the presentation next. Thank you for exposing the fear of the unknown. The next speaker is Dr. Boni, assistant professor in the same college where Dr. Chepsi works. Please start your discussion.
So good afternoon. I thank Team Mindray for this concept, because when the physician insights meets laboratory medicine, it's a synergistic effect, and it makes patient management and treatment more easier and meaningful. Also, numbers and values generated in the lab get a context, and symptoms of the patient get a meaning when this sort of collaboration happens. So Dr. Chepsi had highlighted the challenges that he faces in myelodysplastic neoplasm, and his challenges get translated to me directly in the lab. So through my presentation, I would like to offer maybe a partial solution, if not complete, to how we can early diagnose this condition, what the automated hematology analyzers can offer. So if you have to just note down in points, what are the problems in the diagnostic complexity in myelodysplastic neoplasm, we have that on the clinical side as well as from the laboratory side. So it is very heterogeneous, and it has a lot of overlapping features with non-neoplastic, non-MDS type conditions like megaloblastic anemia, aplastic anemia, and autoimmune disease. Also, cytogenetics, only 50% of the cases do you detect any cytogenetic abnormality, and some you will have somatic mutations, and then you have this clonal hematopoiesis of indeterminate potential, which is age-related. It may present with cytopenia or dysplasia or neither. Now, for the morphological point of view, where the pathologist is concerned, if there is frank features of dysplasia, everybody can pick it up. But when you have these borderline or very mild features, it's very subjective. So that takes time. And every third or fourth marrow, which is coming from clinical hemat, has a query MDS. And we do not approach this in the end of the day. We usually start it in the morning, the fresh mind. And then we have these buckets into which most of the patients get unclassified till we get further input from the molecular and the cytogenetic part. So the WHO, the latest update, and the ICC, they ask for, or we have to approach this in an integrated manner, making use of CBC, peripheral smear morphology, cytogenetics, molecular and flow. But the first step is the assessment of dysplasia. And this will help to give a guidance for further genetic testing and making clinical decisions. Now, for this, we would require more precise, reproducible criteria in order to select and justify the next costly investigation that has to be ordered. So this is where the 7th generation automated hematology analyzers offer some solution. There are different manufacturers based on different technology, which give a variety of parameters, which may help in screening or early picking up of these MDN conditions. And if we browse the net, we will get a lot of research articles in which investigators from different parts have studied different analyzers and what input it gives in order to pick up MDN cases. So in my institution, we have the impedance-based Beckman-Coulter system and a fluorescence-based Mindray. So this is a common picture to explain how the principle of Beckman-Coulter, the impedance-based works, that is VCS, just for the benefit of the postgraduates. It is based on the volume giving the size, the conductivity giving the internal complexity, and the scatter, the granularity of the cell. And depending on the scatter, which is based on the optical light scatter picked up by detectors at different angles, you have upper, lower, and median angle light scatter. And these are noted as values, which is generated in the analyzer. So I'm just highlighting some recent study published based on the impedance. So what they have noticed, or what is a consistent finding, is that in cases of MDS, the neutrophil volumes are significantly increased, whereas the scatter parameters, which indicate the granularity or the hypogranularity, are decreased. So this is this can be applied to even MDS MPN cases. So I'm just going through a case of MDS MPN in our hospital. 76-year-old male who presented with generalized tiredness and non-specific symptoms, mild splenomegaly, and he had anemia, thrombocytopenia. There was a leukocytosis, left shift, and monocytosis. This was his peripheral blood. The RBCs had showed evidence, it was macrocytic with evidence of dyserythropoiesis. There was Cabot ring, Hubble-Jolly body. NRBCs were showing nuclear budding. And coming to the granulocytic series, the neutrophils were hypersegmented and hypogranular, picked up morphologically. On the right, we have a normal neutrophil with the granules. Okay, so he had larger and hypogranular neutrophils. And this was a dysplastic form, which we call the ring form or the donut form. And we had monocytosis. So this was the impedance-based scatter plot, which comes the WBC differential scattergram. So on the right, I have put a normal control. The population highlighted in purple is the neutrophils, nicely separated from the green population, which is monocytes. But in our patient's case, we can see that it was hypogranular. So the neutrophils have merged with the monocytes. So this gives you a visual detection on the automated analyzer, a tool in order to pick up that this is a case of possible MDS or MDS MPN. So when you go to the cell population data, in this patient, it was found out that the volume was high. The neutrophil volume was high, 182, and all the scatter parameters were low when compared to the normal range. So this is giving you an objective measurement of a finding, a morphological finding, which could be subjective. Now, the fluorescence, this is the second instrument that we have, the Mindray BC 6800 Plus. It's a fluorescence base. It incorporates a fluorescent dye and gives us signals, forward scatter, side scatter, and fluorescence. And based on that, each leukocyte gets a measurement in 3 axes, X, Y, and Z. The new X tells us about the granularity. The new Y will tell us about the fluorescence intensity. And the new Z will give us an idea about the cell volume. So this is an article in 2024, which studied the utility of these cell population data from the Mindray machine in order to pick up MDS. So they have found out and they have compared this with patients of non-MDS who had aplastic anemia or megaloblastic anemia. And what was a consistent finding was that all these neutrophil parameters in the XYZ were low when compared to the other case, non-MDS group. So I'll just go through a few cases where we tried to find out if this is applicable, if this is useful. So the second case is a 45-year-old female. She also presented with breathlessness, palpitations, fatigue, pancytopenia. Outside B12 folate was normal. And she had a mild splenomegaly, and she was referred for evaluation of pancytopenia. And the CBC done here, it revealed anemia, leukopenia of 1000 with neutropenia and thrombocytopenia. So we looked at the cell population data, and this showed that the NUT X, Y, and Z values were significantly low when compared to the normal range. Okay, and in the peripheral smear, when we looked into the neutrophils, it appeared misshapen, abnormally segmented, and slightly hypogranular. A bone marrow was done. It was markedly hypercellular, and we could see it was erythroid hyperplasia with all that features of dyserythropoiesis, megaloblastic maturation. And on the lower side, we had even a pseudo-Pelgarieu anomaly myeloid neutrophil. The megs were disjointed. Okay, so all the features of multilineage dysplasia. And on Pearl stain, we got numerous ring sideroblasts. So when we see a marrow like this, everything is explained. This is a case of MDS with low blasts. Okay, and this patient came last week only, so we are awaiting the molecular and cytogenetic report. So now coming to another case of megaloblastic anemia. This was a case, and this also presented with pancytopenia with elevated MCV and mild thrombocytopenia. And we looked into the new X, Y, and Z values, and this was fairly in range. Only the Z value, new X, Z was high, probably the macrocytic component. So this is the finding in the peripheral blood, macrocytic with hypersegmented neutrophil. Again, a hypercellular marrow, megaloblasts, and hypersegmented neutrophils. And we have the giant meta. So all this is like, this is a one exam marrow for the postgraduates also, megaloblastic anemia. So here we can see that even though there were overlapping features of dysplasia, the cell population data gave an insight to exclude MDS out of this. Coming to a case of aplastic anemia, a patient who presented with similar complaints but with some ecchymotic rashes, pancytopenia, and he was referred for pancytopenia management. The CBC showed severe anemia, leukopenia, neutropenia, and severe thrombocytopenia. Here also, this is in the peripheral smear, the neutrophils, they don't look hypogranular. They look fairly normal. And even here, the new X, Y, and Z values are within range. So this is, and the bone marrow was aplastic with cellularity less than 10%. So this is a case of very severe aplastic anemia. Just to say that all these three patients present with pancytopenia, similar clinical complaints, but the 2 ml EDTA sample that comes to your blood, and if you run it on the CDR mode or the extended mode, you will get parameters that could provide an insight to what you would be dealing with. Now coming to this case, which was discussed by Dr. Chepsi, this was, I won't go through the details. This was the case that presented with pancytopenia. The NUT X value was low. The Y was low, not low. The Y and the Z were within normal, but the NUT X was low. And in the peripheral blood, this was the spectrum of the neutrophil morphology. So for me, this is not like very dysplastic. If at all, it's just mildly hypogranular. So at this, if I see this, I will not say this is frank MDS or so. And this was the marrow, the first initial marrow. It was hypercellular, and there was this features of mild dysplasia, mild megaloblastic change. Again, not enough to quantify or say, call it and label it as MDS. there was no ring sideroblast either, just some hyperlobate, monolobate, and occasional micromegs contributing to dysmegakaryopoiesis. So, like it was mentioned, the cytogenetics was normal. The NGS picked up a DNMT3 KRAS of uncertain significance in the report, but if you look into it detail only, you can correlate it with probably there was a clonal, it's a chip event has happened. So this was considered as low risk MDN and initiated on TAB. Patient was on continuous review and she was transfusion dependent. And then she had a episode of epistaxis palpitation. She was admitted. Again, this was the CBC. It showed a severe anemia, leukopenia, neutropenia. Platelets was more or less stable. Here also, we just looked into the neutrophil cell population data, new X value, which is high, the granularity part component, that was low. The rest other two values were within normal range. The autoimmune workup was strongly positive. And at that point, the marrow was variably cellular. It had hypocellular and focal hypercellular areas. And there were some few scattered blasts. On flow cytometry, it was quantified as 5%. So at this point, it became whether there was a confusion whether was this an MDS that evolved into, is going into aplastic because there's an immune dysregulation happening, or is it a hypoplastic MDS now? Or is it the autoimmune disorder causing all the pancytopenia with which mild dysplasia can be related with? So here also symptomatically managed. This is the third in May. The patient was admitted again and the CBC was similar findings with the new X and Y, new X, Y, Z parameters. But this time it was markedly hypocellular, the marrow. Few cells to comment on the morphology or quantify. And this was having scattered immature cells quantified as 14% plus. So because some clonal event now has progressed because of the presence of blast, this has been labeled as myelodysplastic neoplasm with increased blast and azacitidine. So this patient has been here for 1 year, almost 1 year, and he has just been following up. And at this point, whether that new X value, the low value which was encountered in the first, would it be sufficient to call it labeled as dysplasia? So just to summarize that the cell population data can offer a window for detecting for an objective assessment of morphological dysplasia. You can get a visual scatter plot changes to detect abnormal or deviation from the normal morphology. And this can guide, help in reflex testing to guide what should be the next test to be done. And it helps to, at least when the mild dysplasia findings are there, it could throw more objectivity into its assessment. Thank you. I acknowledge my teacher, Dr. Sukesh and Dr. Naveen Kakar, and team of the clinical hematologists, and our excellent lab management and my technicians in the hemat lab. Thank you.
Thank you. Paper is open for discussion. Any questions? There were 5 different clinical scenarios. The first paper by Dr. Chepsi, the stress of the clinician in explaining to the patient what he is suffering from. So I don't think we have an answer to that at that moment. And the second, the cell population data, how it supports your what do you call, your marrow findings. I think that's also an excellent. So somewhat, I think the pathologist may be a little bit satisfied with that help, but the problem of the clinician remains. I request Dr. Sukesh to throw a light on this change of the name from syndrome to neoplasm. Would he have changed the syndrome or would he have changed the dysplasia? That is also I want to know, because he is very much bothered about this semantics.
No, sir. I think it has gone beyond syndromic. So I think neoplasm covers a lot of possibilities which are there in MDS. In those days, we had only 5 entities we were worried about. Now it's gone beyond that. So I think even proliferative also they've gone into neoplasms. They're not myeloproliferative syndromes, yeah, or myeloproliferative disease. In a cell counter which uses fluorescence to count the white cells, I mean, do the differential count for white cells, hypogranularity cannot be ignored. It's very, very significant. Because what happens is when the dye has to penetrate the cell, they make holes in the cell and the cells are shrinking. So in a shrinking cell, granularity can be crowded. And in that granularity, if it becomes hypogranular, it is very, very significant. You can't ignore it. In VCS, maybe you can have other conditions like sepsis and all those things. In fact, I thought your first case was sepsis, not MDS. So, because it was overlapping into the monocyte area. And in the VCS, one of the slides that you showed, there is a very important parameter that you ignore to block. The conductivity of the neutrophils was very low. It was 136. When you have Pelger-Huey neutrophils in the peripheral blood, the conductivity is very low.
Thank you, Sukesh. Before we close the thing, I am worried about this dysplasia because I'm a very old pathologist. Dysplasia means disordered arrangement. Placine means arrangement, no? So there is no disorder in the arrangement except probably for the megakaryocyte, like where it is placed. So are we rather misplaced in calling it dysplasia is a big question in my mind. Maybe it's a question in your mind also. Maybe the next Manthan, after a little bit of more Manthan, we'll come to the answer that. Because of shortage of time, I am forced to close the discussion. Maybe a word from Dr. Mahesh.
So the other closer differential diagnosis when you are in doubt whether you are dealing with the myelodysplastic syndrome is one, carefully looking for the peripheral smear to see whether you are seeing any NK cells or T LGL cells. There have been certain scenarios wherein we have missed these T LGLs and NK cell LGLs. If you are not carefully looking into those kind of cells in the peripheral blood smear, because it is very difficult to pick up these cells on the biopsies. And there have been instances wherein karyotyping, fish, everything has been normal, molecular studies has been normal. Those are the subset of patients where even like you don't have much of dysplasia on the marrow, retrospectively look back into the peripheral smear, see whether these LGL cells are there and run a flow cytometry, which may tell us a diagnosis about chronic LGL or NK cell leukemias. And the treatment is totally different about this spectrum of diseases. And there have been certain situations wherein we were having cytopenias, but was not meeting into a clear-cut myelodysplastic syndrome. Again, karyotype, fish, everything was normal, ANA profile being positive. Sometimes challenge of steroids has helped in these kind of situations wherein we have made a diagnosis of autoimmune cytopenias, especially when you have a clinical exome sequencing which is bang normal and very mild dysplasia. You should always keep it in mind. Maybe you might be dealing with other diagnoses other than MDS.
Any other questions or any other suggestions? I think no questions. So may I call Dr. Sankar again on stage to felicitate our speakers. So may I call Dr. Chepsi to be on the stage, please? Yes. Thank you. Thank you very much, Dr. Sankar, and both the speakers, Dr. Boni and Dr. Chepsi. now the most awaited talk of the day from two legends. So may I call Dr. Shashi Apte on stage, and may I request Dr. Joy and Dr. Sankar to chair the session together, please?
At the outset, let me thank Mindray, the local organizers, and obviously Sukesh. I will not thank Sukesh because it was like an order, Shashi, you're coming. So I said, no problem, Sukesh, it's always a great fun. Sukesh and me, our association dates back to 34, 35 years. And let me honestly tell you, my interest in lab really increased because of, while I was a student, I had a colleague like Sukesh and another colleague, Dr. Ashwin Patel. And we used to have a great time in the labs. I sincerely feel that every clinician must spend the time in lab, and every laboratory person should spend some time in the wards. It is very important. And with that, this is a topic Sukesh said that Altius Citus for Fortius is an Olympic logo. And for me, it means in this context of the talk is that we expect faster, quicker results from the lab. We expect taller decisions by the clinicians, and that leads to the stronger patient. So that is a very apt statement even for clinical medicine. When Sukesh always gives me a talk, my first reaction always becomes, I should be in the audience and listening to this talk, not giving this talk. He always puts me in a difficult position. So basically, as a clinician, everybody has a dream. And every clinician feels that I must cure every of my patient with optimal treatment without complications. It should be higher, faster, and stronger outcome. Treatment has to be accessible, available, and affordable. Purposely, I put things in affordable because in a country like India, a lot of things are available and accessible, but because of the certain financial constraint, they may not be affordable. But if we need or if we reach a quick, reliable, and robust lab reports, we will have excellent outcomes in the patients. Every disease has a risk factors, and some risk factors are universal. Let it be any diagnosis. These risk factors exist. First is a delay in correct diagnosis. If you delay a correct diagnosis, there was the discussion of the case of APML. If the APML case had not been diagnosed, a good risk APML could have died because of the intracranial bleed. So we have to avoid delay in correct diagnosis. They should not be delay in correct treatment. Sometimes correct diagnosis has been made, but treatment may be wrong. And that should be avoided by the clinical team. And avoid complications. A lot of complications are time-bound. Lot of, like, we know, treat leukemias, we treat malignancies. There is a parameter, especially in leukemias, which categorizes into high risk. If WBC count is more than 1 lakh in certain malignancies, it's a high risk leukemia. Had this been diagnosed 15 days back with WBC count of 5,000, could have been a low risk leukemia. It's just a time-bound phenomenon, the risk category. It's not moving. Yeah. And we always have therapeutic and diagnostic biases. Never have a diagnosis made in the mind till you have given some thought. We immediately think this may be megaloblastic anemia, but may not be megaloblastic anemia. Be very careful before you have immediate reaction to the given situation. There was a survey done long back in Maharashtra about importance of laboratories, and it had a very funny outcomes. The question asked was, how important is the lab in clinical practice? Some people said, one-third people said important. One-third people said very important. And remaining one-third said, can you move the slide because this is not moving? And surprisingly, one-third of the clinicians said the labs are not so important. It was a very eye-opening survey. It was not a big sample size, but various departments, various subspecialties were asked this simple question. What do you feel about the role of the labs? Also, the issue comes when there is a mismatch in the clinical diagnosis and mismatch in the outcome of the results. A clinician is expecting some result and result doesn't come into that alignment. Immediately the reaction by the clinician, hey, this is a wrong report. It may not be wrong report. Your premises were wrong. Report may be correct. And then it leads to a confusion, what to choose, a clinical diagnosis or a lab report. And it can go both ways. Is it better to rely in this situation on clinical diagnosis? In my mind, though I'm a clinician, my answer is definitely not. If there is a confusion, have a dialogue with the lab, resend the test, redo the test, and try to sort it out. Then the question arises, if the clinician decides that whatever result comes, I have made my decision to take a action, why do you need the labs? And that is the most dangerous situation a clinician can lead to. We must understand that laboratory and clinical medicine are two wheels of the same vehicle. And these mismatches occur because of the non-robust decision, non-robust thought by the clinician, as well as non-robust lab report. There is a saying that you can't clap with one hand. For a clap, you need two hands. And for confusion, you need two departments, two people. And it is our role, it is the role of modern medicine that how we can reduce this mismatch. When mobiles started, we had these kind of mobiles. But with time, we have graduated to these kind of mobiles. Probably it is I-17 or it may be I-18, it may be I-20, and it will keep coming up. Same thing has happened with clinical medicine as well as laboratory medicine. 1981, I joined MBBS program. This is how I used to do the cell counts with using Neubauer's chambers. Even today, I find these devices, Clay Adams devices, in the laboratories. I don't know what is the real use of it because a cell counter, if you give a WBC count of 8,200 cells, it is making a differential on 8,200 cells. We are doing a differential on 100 cells. How does it matter that machine gives 52% lymphocyte, your Clay Adams gives 49% lymphocyte? Clinically, patient doesn't change. We should be optimizing our resources. We should be optimizing our time and have a fruitful discussion rather than clinging. I call this clinging to the history. It is important. In rare situation, you may need it. I'm not saying that this is not needed, but you have to be realistic. The role of a human eye, even today, cannot be forgotten. Looking at the slide is very important thing. In my own department, I always see my own slides. Whenever a patient comes for the first time, I see PBS, I see bone marrow aspirate, I see his lymph node biopsy, I see his bone marrow trephines, I see the flow cytometry charts. And this is because of the training and the interest I had colleagues like Sukesh. I'm not expecting this to happen, but if it happens, that is very good thing because you can have a dialogue with your laboratory team. we moved from these kind of reports to newer machines. And it leads to the question how we change. There's a beautiful book called Behavioral Psychology by Daryl Kahneman. He's a Nobel laureate. He received Nobel in 2004 or 2005. There is, whenever new concept comes, there is a behavioral psychology. Some people readily accept it. Some people are skeptical. Some people just refuse to accept it. And that thing was shown by that question asked in state of Maharashtra. What is the role of laboratories in today's medicine? You got three answers, three sets of answers again. So today's scenario, that more and more dependent on investigative medicine has happened. And it is true, that has happened. There are more and more things are written about the laboratory tests, laboratory devices, reagents, and there is a paradigm shift in simple things. Not that many changes have happened in clinical medicine. Like when we clinically examine a patient, splenomegaly, the description of splenomegaly in 1950s, 1980s, 2000 and 2050 will remain the same. But I'm sure by 2050, Mindray will have a different concept of cell counters. So this is very important to realize that more inputs have happened on the laboratory side than the clinical side of the clinical examination, I mean to say. I'm not talking of therapeutics. I'm not talking of investigations in radiology. When you clinically see a patient and you order a test, there is a difference in the outcomes and the technologies. And this is a byproduct of time we live in. A lot of new changes have been happening and we are exposed to it. Sometimes there is a phenomena called as the incidentalomas. Sometimes happens once. It may be a rare diagnosis. But when that kind of a finding comes, every time you think of that rare diagnosis. It's a dangerous scene on the side of clinicians. And same thing may happen in the laboratory side. So we are blindly asking a lot of tests when certain incident has happened in our life. That should be stopped by the clinicians. May not be required. You're wasting time. It is a waste of energy, money, time, resources, manpower, and leads to patient anxiety and leads to therapy-related complications. We should not be treating a lab report. We should be treating an individual. Lab reports are incidents. Patient is a reality. And that thing should not be forgotten. When we take a decision, we are not, I strongly feel, we and Sukesh, we always used to discuss, I would like to see a lab report or say CBC report without the normal reference ranges. Why these normal reference ranges should be printed on the report? Doctor should know. If he has a confusion, should ask the pathology. Why patients should know the normal ranges for that given parameter? It leads to a lot of confusion. Let them come, let them ask. And these things will change the philosophy of modern medicine. A good, reliable laboratory makes a whole difference in the patient management. It's a fact. It's not enough to ask for a test. A lot of times tests are asked. Reports are not collected. I get wild when residents have not collected the reports. Man, you have sent 5 o'clock in the evening, factor 8 assay. Why at 9 o'clock this assay report not collected? If you are not going to collect it, why the hell did you send it? So that care has to be taken by a physician when you are taking a decision or asking for a test. It is also important to know some basics about the test that he asks for. He should know about the correct interpretation and he should also know about the fallacies of that test. A lot of times clinician may know the correct interpretation but may not know the fallacies of that test. So most important lab test in medicine according to me is hemogram with PBS examination. In the bracket, I would have entered what is called as the hemocytomorphometry, which Sukesh has been strongly advocating for last 12, 15 years, that slowly you can get away from looking at the slides. And I'm sure that thing will happen. This was the man who carved the era of modern CBC analyzers. He was working on the analyzers to see the particle contamination in petrol, and he realized the same thing can be used in humans to do the CBC analysis. And that we know what is the Coulter principle. I won't go into the details, but we must ponder certain points. That automated instruments are designed to produce accurate and precise blood counts on specimens which are either normal or show only numerical abnormalities. This point is very important, that when we ask the test, we do not know what the variable is going to be. We do not know what reports to accept. When Virat Kohli enters a ground, you can expect that at least he will score 40, 50 runs. That kind of guesswork we cannot do. Whatever your experience is about the test, when you ask what the report will be, and that has to be kept in mind when we are asking for a test. It may not recognize all the significant abnormalities that can be recognized by a human observer. Over a period of time, I'm sure this gap will reduce, but there is a gap today. They alert the instrument operator when the specimen has unusual characteristics, and that could either lead to an inaccurate measurement or require a review of blood film. So Westgard rules have to be really stringently applied by every laboratory. And unless there are properly set Westgard rules for your machines, you are going to run into trouble and patient will land up in trouble. And this is often regarded as flagging, and these how to interpret this flag has been now well established. So the question in my mind, can CBC analyzers help me in the rapid diagnosis of malaria? That is my first question as a clinician. And this I learned from our great teacher, Dr. Ani Sudarshan. Every morning at 7:30, 7:45, Sukesh and me are just settling down after our morning coffee. Madam will walk in. Let us pull out and look at the slides which have been reported malaria negative by you people in the night. Her logic was very clear. I once asked her, ma'am, you come down, but you first see the malaria slides at 7:45, 8 a.m. in the morning. She used to say, Shashi, Sukesh, if I pick up one slide with malaria positive, diagnosis is made, investigation stops, treatment starts. That really opened my eyes. A simple test, because malaria is very common. Malaria is very, very common in our country. So whenever these CBC analysis came, I realized the importance, because pathologists will say how difficult it is to pick up. It is more difficult to pick up a dysplastic change than pick up a one parasite in a given slide, because it may be in small number. And if the machine helps me, it will really be a boon that with extreme sensitivity and specificity, we can diagnose malaria on CBC analysis. Whether it can give me an early diagnosis of sepsis. When we are dealing with 100 WBC count, patient has febrile neutropenia, blood culture report hasn't come, there is a tachycardia. Can CBC pick up probably this is going to be a culture positive sepsis? Because many times and again, microbiology labs have improved dramatically. So culture negative is culture negative for me in my institute. But yes, the patient is sick, where I'm heading to. So whether that clue can come from CBC analysis. Can cause of fever be told to me by the machine, whether it is bacterial or viral? Because again, the expenses done, the investigation asked for would be completely different. And most important thing, early identification of leukemias is very, very crucial. And diagnosis of anemia. I won't go into too much of details of diagnosis of anemia, because diagnosis of anemia by CBC analyzers is a different lecture by itself. It's a huge lecture, and Sukesh would agree with me that he will cover some of the aspects in his talk. And truth about the platelet count. Today, the lot of unnecessary investigations happen because of a wrong thrombocytopenia. It is very, very crucial that we do not fall into that trap of long platelet count. Can I do without microscopy? Probably not. Even today, microscopy has its definite role. Probably not. Is this a question answer to the human ego? Again, not. It is not a outcome of a human ego that you can't go away with microscopy. It is a fact today. Can machines replace human eye? Maybe, may not be. But yes, we have to make an effort. Can I be attached to analyzer? I think it is possible. After my last probably 40, 50 years in medicine, only one thing I have accepted, that a man cannot become pregnant. Everything else is possible in medicine. Everything else is possible. And I've really every day, I'm living longer, getting exposed to modern medicine. Sometimes I get amused. Look at CAR T cells. 20 years back, it would have been a huge concept. Look at gene therapy. It's a huge concept. Who would have thought that hemophilia can be cured? It is changing. So this is my bottom line of medicine. A man cannot become pregnant. Everything else is possible. And this is a new concept that Sukesh is enrolling. It's a great work he has done about this, trying to go away from microscopy. So as I said, malaria diagnosis is important, and I already elucidated that it gives a full stop for investigations of pyrexia. Pyrexia of unknown origin. If we had done the costing, if you have to do all the tests listed in pyrexia of unknown medicine, can anybody guess what would be the cost to the patient? Anyone in the crowd? It is 12 lakh rupees. Just if you have to do all the tests. And at the end of 12 lakh rupees, we will reach the diagnosis. That can be avoided. Again, as I said, if we can have this separation, it is going to be very, very easy for the management and much more cost-effective management. Early diagnosis of leukemia is very important. It will lead to early chemotherapy, better absolute neutrophil count and platelet count at the start of chemotherapy. Because we know today the first 2 weeks complications are directly proportional to ANC and platelet count at what you start the chemotherapy, especially in acute myeloid leukemias, even in lymphomas. The early treatment will lead to early infections, less transfusion support. Like in acute leukemia management, first 4 weeks, transfusion support can be high. So you can imagine, I start a chemotherapy at 10,000 platelet count versus I start a chemotherapy at 120,000 platelet count. Cost is going to be completely different. And this cost effectiveness will definitely come with the modern medicines. Persistent hypochromic macrocytic anemia with normal iron profiling is a big issue in our scenario. And there definitely the machine gives the best clue. And it is very important in pregnancy. Very, very important in pregnancy. This is the only one aspect of anemia I'm going to elucidate in my lecture because, as I said, it's a huge thing. But even today, the number of beta thalassemia major children born in our country has not come down. We have not reached that diagnosis. And I curse that mostly the OBGY people. And the reason is very simple. No OBGY consultant sees the thalassemia major child after the delivery. It goes to the pediatrician. They don't know what is the agony of having a thalassemia major child. A lady gets registered at 6th week of pregnancy, has a parameter suggestive of beta thalassemia minor, no workup is done, and thal major child is born. And with today's medicine, it is extremely simple to pick up thalassemia minor in the community. there's a rule of three. RBC count into 3 is roughly equivalent to hemoglobin. Hemoglobin count into 3 is roughly to the hematocrit. If there is a disparity here, you are either dealing with beta thal minor or alpha thal. And that cannot be missed. This is another algorithm where anemia would be approached depending on MCV. And coming to the last point about the truth of a platelet count, wrong interpretation of borderline low platelet count is very important. Pune is a migrant city. We have a lot of migrant IT professionals coming from Bihar, West Bengal, Northeast region, and we get a referral for 70,000 platelet count. There is an entity called constitutional macrothrombocytopenia, or also called as Harris's syndrome, where platelet hover between 70 to 100,000. MPV is really high. Looking at just MPV and looking at the name, if the name is Barua, Sinha, Kumar, Srivastav, you know that this is probably a constitutional macrothrombocytopenia. We also should look at the high MPV. High MPV will tell you, a clinician, that the platelet count, though reported, is 50,000, maybe 150,000. So don't jump to the conclusions and don't give a call to the lab and find out what is it. There is the ADT effect. A lot of clinicians are not aware what is called as the ADT effect. So lab should look into every thrombocyte and make sure that there is no ADT effect, because that clue will only come from the lab side. And schistocytes can get counted by machines as platelets. And microangiopathic hemolytic anemias oblique TTP is a very lethal condition if missed. So looking at the schistocytes, you may have platelet count of 70, 80,000. But when you look at the slide, you can have less platelet and schistocytes. And modern machines do pick up schistocytes in the CBC analyzers. So if you give a thought and decide to use the machines properly, especially in the thrombocytopenic patient, a lot of unnecessary and wrong investigations can be avoided. So these are my last couple of slides. One of the offbeat wish in the lab, I've been talking with my IT colleagues, can it be connected to my iPhone? If it goes to the iPhone, if I get a validated reports, I don't have to go to the system and look into the computer. It is a dynamic process that goes on when you can link it. And in our institute, we are trying to do that all consultants, all residents, analyzers can, whether they can be linked. So that is one wish I have. Can machines generate the data? We should not be asking. Machines should be automatically generating. Say, to give an example, in last 1 year, I had so many high MCV patients, and what was their outcomes? Something like that. Can machine do the auto-calibration? And certain wishes may erupt with the development of new machines. So these wishes are unknown in my own mind, but they may erupt when I get exposed to something new. There are definitely missing links. It's a question in my mind, have we made the best use of data available from current analyzers? And I feel no, we are lacking. As a human race, we have lacked. There are a lot of things in that screen which we are not interpreted or interfaced. There may be certain parameters staring at us, which we are ignoring it. Have we become complacent with these new machines? That we have become relaxed with our routine work, and that is not taxing our own brains. We have to collect data from analyzers and retrospectively analyze. And can we predict the result of the next test that I asked for? Are the missing things. So to summarize, more emphasis for quality parameters has to be assessed. New parameters will emerge, and we have to analyze those new parameters. We need tighter CVs in these machines. Integration of cytomorphometry with analyzers may replace the need for microscopy, may replace. We should have extreme clarity in our minds why we are doing A action, B action, why I am interpreting these reports in ABC manner. And can we improve upon the predictive values of machine as well as human thought. We cannot predict how a human can think. So one take-home message I always say, pathology is a clinical branch. Don't say we are pathologists, we are non-clinical. There is nothing non-clinical in medicine. Every branch in medicine is clinical because you are taking a decision in interest of the patient. When a decision is made in interest of the patient, you cannot call that branch non-clinical. It's a clinical branch. This lecture I always dedicate to this man because without Kulta principle, we would not be standing here and giving this talk. And I'll say thank you. We are forcing a torch in one direction, but the answer may be in another direction. Thank you.
Thank you very much again, Mindray, for the invite. And thanks, Shashi, for, I think we have got the wrong slides here. So Sashi was asked to tell the wish list from a physician, what he would expect the cell counter to provide him. He's mostly bedside physician. He's a clinical hematologist, but he's probably the only clinical hematologist in the world right now who sees his own patient smear. Am I right, Chepsi? Okay, so I'm not asking you to see smears. So anyway, Bonnie's there. He has also got somebody like Bonnie with him. There was one more idiot like him in Ahmedabad. Fortunately, he has left the country. So now he's the only hematologist in the world who sees his patients smear. So he's got a microscope in his OPD. So after the OPD, he'll get the tray of slides and look at the smears. The one in Ahmedabad, he used to use those keys. And in most of these patients of there after chemotherapy, they have got cytopenia. And he's pressing key one by one. He'll take at least 15 minutes to finish one differential count of 100 cells. But he'll do it. Okay, fine. So let's go to the... Fine. Okay, should I... Security alert. Fine, we have seen this for the 10th time today. Yeah. This was a picture taken about 10 years back when I was a member of the lab sciences committee. And what they do is they take pictures of individuals and then they make it a group photo. Yeah, fine. Thank you very much. Your default speaker has changed to speakers. Okay, fine. So higher, faster, and stronger. Chemocytometer is still not finished. It's still progressing. It's still advancing. So that is the emblem of CMC. And that's the hand of God, not by Maradona. Okay. So peripheral blood counts and morphology remains the most important diagnostic tool in medicine. Issue is, can cell counter do better morphology? Now, this is an output that you get from a cell counter. For example, this is a Mindray cell counter. It gives you all the numbers, the values which most of the pathologists see. But it also gives you some pictures like scattergram, histogram. It's of interest sometimes for it to be seen, but many people ignore it. It may give you some information and messages. So why could we think or assume that cell counter can do better morphology? Because we, as Dr. Shashi mentioned, it analyzes cells 80 to 100 times more than what a morphology checking, a manual checking process will do. And therefore it also it makes a proper output. Can it be more specific for a disease or a disease process so that it can help early diagnosis at a very, very early stage of the disease? It can also possibly indicate outcome and direct prognostic identification of the disease. Sometimes it can be a life-saving tool. And in my experience, I have saved quite a few lives with just cell counter morphology. So we all know this electrical impedance, across the field, the pulse is directly proportional not only to the number of cells, but also directly proportional to the size of the cell. And the contribution of cell counter to these two parameters, the red cell histogram and the platelet histogram. Red cell histogram has actually changed practice of the most common hematological disorder in the world, that is iron deficiency anemia. You cannot manage iron deficiency anemia without MCV, without RDW. Of course, hemoglobin is important. The other thing is these are directly measured parameters. Though MCV is derived, but it is from a direct measure of the RBC histogram. Now in platelet count, what is directly measured is not the platelet count, it's the histogram. Histogram is a reflection of the direct measure of the platelet count. Platelet count is derived from the histogram. The area under the curve is the platelet count, not the individual pulses. So what is directly measured is the histogram. So never ignore the histogram because that is direct measure. And of course, you have the white cell where everything is lysed because white cells are only in 1,000, red cells are in millions. So you have to lyse everything. And then you have the white cell histogram. So white cell histogram, of course, we know that you have the small nucleus of the lymphocyte there. Then you have the 4 or 5 lobes of the neutrophil, the 3 lobes, the 2 lobes, then the eosinophils, the basophils, and monocytes. Though they are large, but once the cells lyse, only the nuclear, the particulate material is the monocyte. So monocytes are somewhere there, always there. So when you get a histogram like this, where the lymphocyte has been completely dwarfed, basically means the white cell count is more than 1 lakh. So where the lymphocyte has been dwarfed, the white cell count is more than 1 lakh. And most of the cells are neutrophils and probably its precursors. You can see the left shift there. And it's like a bell-shaped curve with the peak closer to the neutrophil side. Wherever you see this histogram in the world, there is only one diagnosis, and that is CML in chronic phase. In chronic phase, not just CML, CML in chronic phase. Now, when CML progresses, when it goes to blast crisis, you can see the same histogram, but the blast appearing here. When it goes into accelerated phase, you can see the peak shifting from there to here. That's because of basophils. And the CMML is a mirror reflection of the CML histogram. So just looking at the histogram, you can make a clear-cut diagnosis. You don't even have to look at the smear. Okay, now that is from 3-part, we talk about 5-part. 5-part differential counts are available, and of course, they are based on platforms. Like, for example, this is the VCS platform that Dr. Bonnie was talking about, and this is the fluorescent platform where x-axis is scatter and y-axis is fluorescence. So, it's interesting that, all of you are morphologists and you have seen a neutrophil. Mostly it's heterochromatin, dark staining part of the nucleus. The euchromatin is little bit. So euchromatin, it attracts the fluorescent dye. So those cells which have more heterochromatin, they will be having low fluorescence. So you can see that the worst heterochromatin is in the eosinophils. So that's why eosinophils are slightly lower than the neutrophils. And these are the small lymphocytes because they have more heterochromatin. And then as you say that the euchromatin is there in the larger lymphocytes. So these are large lymphocytes based on fluorescence alone. And then of course, monocytes are mostly open chromatin. So they take up more RNA dye. And this is based on the staining, the neutrophils get stained. So there's more absorbance by the neutrophils and of course more by, so this is the cell counter what Dr. Shashi was mentioning about peroxidase staining. So here it's not peroxidase, it's chlorosol, but similar. The advantage of the cell counter is that when cells come out of the gating area, the cell counter will tell you that there is an abnormal population of cell. It can even tell you there is a blast. Sometimes it can even classify the blast as lymphoblast or myeloblast. So that's an advantage. So thing is, and actually based on the guidelines given by the ICSH on smear review criteria, all suspect flags can become slide review. That means you have to make a slide. So when blast flags are there, generally the rule says make a slide. The machine has already told you there's a blast, and most likely there'll be some, there'll be some thrombocytopenia. There'll be, hematology doesn't happen in absolute. When something happens, something else also happens. There'll be anemia, there is thrombocytopenia. Now, machine has already told you there is a blast, and maybe you can transfer the message to the hematologist, there is a blast. What are you going to do by looking at the smear? You will look for an OR rod. You will say this is a lymphoblast. You'll try to show off your talent. This could be a myeloblast. Hematologist is not interested in knowing anything from your information. They only want to know there is a blast or not. Because they will wait for the flow cytometry report. That is only when they think. Even if you report myeloblast or lymphoblast, they are not going to even look at it also. They are going to do a marrow. So in where the place I worked in one time, Chittoor, when blast flag comes, I will report. Peripheral blood shows blast. Kindly suggest bone marrow and flow cytometry for further categorization of leukemia. The hematologists are happy. They are very happy because I have informed them the patient has got leukemia. And cell counters are fantastic in identifying leukemia. Of course, there can be a false positivity also, but some cell counters are quite good at it. Now, Dr. Boni was talking about cell population data. Now, what is cell population data? Like MCV, RDW of the red cell is the population data of red cell. Similarly, the machine is anyway measuring the neutrophils, the eosinophils. It also gets data on the size of the neutrophil. So mean neutrophil volume, the mean scatter of the neutrophil, the mean volume of the lymphocyte. So they are cell population data. Sometimes when you're doing studies, it's good to have cell population data because scatter plot, there is one extra spot there, okay, it's a lot of subjectivity there. But when you use cell population data, it makes that very objective because cell population data is objective data. And when you do studies, always good to have a reference range because you need to know what is the normal. So this was a reference range obtained on 3,000 healthy blood donors. And we compared this cell population data of neutrophils, lymphocytes, and monocytes with data from Europe, from US, and 2 other centers in India, and they were exactly the same. So how do I use cell population data? So this is a 43-year-old male who is recovering in ICU, day 16. He actually had a complex urological surgery, after which he developed fever, sepsis. He was covered with so many antibiotics, you can see that. And I think he recovered. Day 12, he was fine. On day 15, during rounds, the intensive care people and the surgeons decided, okay, we can discharge him tomorrow. So 16th early morning, when the intensivist looks at the patient, he finds the patient quite unwell. And there's a spike of fever. And he sends a sample for procalcitonin. That's a test for identifying whether there's an infection. So procalcitonin was on 0.9, 0.1 or something like that. So he calls me and says, Sukesh, can you have a look at the smear? I said, why? I think the patient has got some infection. Procalcitonin is normal. So I wanted to look for, he says, I want to look for toxic neutrophils. We know what toxic neutrophils are, neutrophils which are having extra granular coloration and Dolly bodies. So if you have got a good stain, you can even see Dolly bodies in the neutrophils. Oh, sorry. So this is the information on this. White cell count is around 4,000. And you can see that most of the population are neutrophils. Even the histogram also shows that these are neutrophils. Now I compare this with a normal scatter plot. That's a normal scatter plot. It's hardly any difference, isn't it? The neutrophils look similar. So there was a study done by Fernando Chavez. This is when he was a student in Miami, in which everybody talks about toxic change. And what is toxic change? Granules. And every cell counter does scatter. So they thought that toxic change means increased scatter. So they did a study because every cell counter does scatter. So he did a study on Beckman-Coulter. And interesting is that in that study, the scatter was low in all the neutrophils in acute bacterial infection. But what was consistent was that all the neutrophils were large in size. So if you look at the neutrophils compared with the reference range, there was neutrophil macrocytosis. All the neutrophils were large, but the scatter was low. They were not able to explain the mechanism, but I think, sometimes Indians are very good morphologists, so they get into morphology in the depth. So we as an Indian explain to them why this mechanism happened. And that is basic understand of morphology of hematopoiesis. A neutrophil will take 5 to 7 days to become a neutrophil from a blast. And in this process of 5 to 7 days, there are 4 changes that happen. All of us are familiar with that. One is the blue color of the cytoplasm will start becoming gray. The granules will start appearing in promyelocyte stage. In myelocyte stage, they are prominent. But by the time it comes to metamylo and band form, you cannot see those granules. That's because as the neutrophil matures, the granules also mature. And one of the indication is that the sialic acid on the surface of the granules, they start falling off as the granules mature. So the granules are unable to take the stain. The basic dye, the azure dye or the methylene blue, they are not able to take up. The granules are very much there. Only thing is they are not going to get stained because they have lost the staining property. And then what happens is the nucleus will become smaller, band form, and then get segmented. And the last thing is the neutrophil, the blast will become half the size when it becomes a neutrophil. Now, when there is an infection, there is a huge demand on the marrow for this. They can't wait for 5 to 7 days. This is sepsis going on. The marrow says, the body says, I want neutrophils right now to fight the infection. This maturation, which takes 5 to 7 days, can happen in less than 1 day. And when that happens, only the nucleus becomes segmented. The size of the neutrophil does not become half. It still remains large. The granules do not lose they're same granules, but they do not lose their staining property. So what is toxic change is only a Romanowski mechanism and nothing to do that my neutrophils have got more granules, I'm going to eat more bacteria. No, nothing like that. It is just that they did not lose their staining property and they have retained the staining property. And the blue color does not completely disappear and they remains in the neutrophil as Dolly bodies. So if you see Dolly bodies, not Dolly-like inclusion, Dolly bodies. When you see Dolly bodies, when you see large neutrophils, when you see toxic changes, these neutrophils have matured in less than 1 day, which can only happen in acute bacterial infection. So coming back to my fellow, look at his neutrophil size. He had neutrophil macrocytosis. If I look at subjectively, I will never be able to say that this guy had large neutrophils. But compared to the normal, his neutrophils were larger, and that data is from the cell population data. Now this, of course, sometimes many of these remains as anecdotes. Sometimes we do studies. Some studies never get published. Some studies, this was one of the studies that got published in which we did neonatal sepsis, looking at neutrophil parameters. And you look at the area under the curve for a diagnosis of sepsis in neonates. That is, when neutrophil volume is large, the area under the curve is 0.8. Procalcitonin area under the curve is 0.65 in any studies that has been done. And even decrease in scatter of the neutrophils, you can see that we looked at neutrophil volume and neutrophil scatter. You can see that there is decrease in neutrophil scatter compared to other controls. So decreased neutrophil scatter and increased neutrophil size was very sensitive for a diagnosis of sepsis, early diagnosis of sepsis. And look at when you combine other parameters of sepsis like thrombocytopenia and leukopenia, look at the specificity of diagnosis for sepsis is almost 100% and sensitivity is 90.7%. This is a Nature publication. Then we did a study in adults where we not only had controls in the ICU, but these are people who come for drowning or hanging or something like that. They do not get infection, non-SIRS or poisoning, and compared to those who are SIRS. And we, for the first time, we realized not only the neutrophil volume, increased neutrophil volume, is very significant in sepsis. But this study also showed that increased monocyte volume, this was the first time when we said that increased monocyte volume is a very important parameter for diagnosis of sepsis. So when you combine increased monocyte volume and neutrophil volume, the sensitivity and specificity is close to 80%. Okay, so now we talked about toxic change. We talked about size of the neutrophil. So now you must realize when neutrophils are large, the same amount of granules are spread across a large neutrophil, the scatter is going to decrease. That's why the scatter is low. Now coming to Dolly bodies. Dolly bodies are RNA because the blue color did not disappear. Now cell counters which are having RNA stain like Mindray and Sysmex. This is the same patient, white cell count of 4,000. Look at the neutrophil fluorescence. This is normal and this is neutrophil fluorescence along the y-axis. And this is also available as cell population data. So when we did a study using neutrophil fluorescence, and this is the Dolly bodies. Beautiful picture, isn't it? Not from internet, my own neutrophils, not my neutrophil, my patients, my microscope, and my staining, modified right Giemsa stain, cheaper than Leishman stain. So yeah. So now you can see the study showed that the area under the curve for increased neutrophil fluorescence in diagnosis of sepsis is almost 0.9. So now you can see cell counter data is so specific in the identification of sepsis. And thing is, we are now only talking about neutrophils. Now we also added monocytes. There is one more thing. Look at this picture. There's no eosinophils in the patient with sepsis. And this is a data that came in 1965 that eosinopenia can be the earliest marker of sepsis. So a study was done when somebody identified that, okay, we did a study. And I think somebody was observing from US and they did a study. And I mean, of course, I was involved. But after 1 year, I asked the intensivist, what happened to that study? Oh, we didn't find the study very significant. I said, show me the data. So, you must realize that the eosinophil reference range published in DESI is 44 to 440, which is 0.04 to 0.44. But in India, that is not the reference range. In India, this is the reference range, 0.2 to 0.6. When I used the reference range in that study, the study became significant. So that's why reference ranges are very important when you carry out studies. So eosinopenia, the area under the curve for eosinopenia for sepsis is 0.73, still better than procalcitonin. And you don't need a high fundamental cell counter for eosinopenia. So there is some cell counter which says that I have got a nice parameter for sepsis, MDW. Have anybody heard of MDW? So MDW is again monocyte distribution width. You must realize we have certain neutrophils which have become bigger, they have got less scatter, and they start getting counted as monocyte. So MDW is nothing but pseudo-monocytosis. So therefore, it's a pseudo parameter. Don't buy a cell counter because you have a MDW there. But look at this. This is increase in monocyte, but the histogram shows there is no monocyte. So you, in fact, straight away looking at the cell counter, you can make out that there is pseudomonocytosis. So this is also increased monocyte, but there are no monocytes here. So this is pseudomonocytosis. Pseudomonocytosis. So now you see pseudomonocytosis, Dolly bodies, large neutrophils, decreased scatter. There's so much parameters available for an early marker of sepsis. And this is true monocytosis. So when you have true monocytes, you can see the monocytes there. So coming back to my intensivist. Coming back to my intensivist, I call him and say that I think your patient has got sepsis. But he said the procalcitonin is normal. I said, do one thing. Anyway, the neutrophils are looking bad. Anyway, you have to start a blood culture. Do a blood culture, start antibiotics. So anyway, while taking the blood culture, send the sample for procalcitonin. The second sample which he may have sent after, morning 6 o'clock, he may have sent at around 9 o'clock was 200. 3 hours. So there's a paper in NEGM. Sequential monitoring of procalcitonin is a better marker of sepsis than a single value of procalcitonin. And we have been doing this for ages, and not we could have also had the same paper in NEGM, but there's no time for studies. So many times anecdotes remain as anecdotes. Okay, so there's another case of fever. So Shashi, cell counters, this space has to be watched. There's already a publication paper that was put up in ISLH in Halifax, in which there was using this same concept, they are coming out with parameters for sepsis. And much earlier detection of sepsis than any other any other parameter. So this is a 35-year-old male with fever. White cell count is around 12,000. Now what you can see is that the lymphocytes are quite widely distributed. The monocytes are also widely distributed, what we call as lymphocyte anisocytosis, monocyte anisocytosis. There is a population of cells which are under the lymphocyte, but smaller than the lymphocyte. They are basically red cells which did not lyse. Okay, so 1, 2, 3, and then there is a population of cells which are out smaller than lymphocytes, which are on the histogram. So there are 4 changes here in this patient. When 4 changes happen, 4 of these changes happen. Maybe there's some battery required for this. There's a patent for that, for a diagnosis of malaria. Malaria is detected. And I'll tell you, in my experience, nothing better than a cell counter to pick up malaria, even if the malarial population or malarial content or malarial index, parasite index is extremely low. Okay, so when you have a population of unlysed red cells under the lymphocytes, it's Vivax. When you have the population of unlysed red cells closer to the y-axis, it's falciparum. Okay, can only the cell counter do it? No, every cell counter can pick up malaria and also identify species. I'll show you another one. Yeah, here. So this is a Vivax and that's a falciparum. Again, you must see lymphocyte anisocytosis, monocyte anisocytosis, and a population outside the. Come on. Okay. Okay, it's going back. There it is changed. Okay, fine. So this is a cell counter where you can see this is normal, just for you to appreciate that. Now there is a population of blue cell which is being counted as neutrophil. So that is not neutrophil but pseudo-neutrophil. Then there is another population of cells which are being counted as eosinophils. So this is eosinophil and this is also eosinophils. But look at where eosinophil is supposed to be. And look where this eosinophil and neutrophils have come closer to the original population of neutrophils. This is Vivax. This is falciparum and this is Vivax. So falciparum is usually here and Vivax is usually here. That's a mixed infection. The same thing can be seen in Sysmex. Same way. Where there is pseudo-eosinophilia, it's falciparum. Where there is pseudo-neutrophilia, it's Vivax. So when there is pseudo, don't blame the cell counter. Cell counter is giving you the right information. Because pseudo-basophilia can be indicating of dengue in certain cell counters. Pseudo-eosinophilia and pseudo-neutrophilia can indicate malaria in certain cell counters. Pseudo-lymphocytosis can be indicating malaria in certain cell counters like Coulter and Horiba. And pseudomonocytosis can be indicating sepsis. But look at the scatter plot or the histogram. Don't blame the cell counter for increased monocytes. So another case of fever, 17-year-old male, he's actually our campus kid. He got admission in IIT Madras and he had fever and the serology showed he's dengue positive. So father brought him to Vellore. He was the head of ICU, the same intensivist who troubles me, and put him in ICU and said that, okay, we'll wait for your platelet count to drop. So Every day platelet count is done, every day it keeps on dropping. And one day it is 4,000. So father calls and said, should we transfuse platelets? I know that platelet transfusion in dengue is very harmful. So I said, normally the WHO says that the risk of intracranial bleed is when the platelet count is 1,000. And he believed me. I will not believe anybody who says the platelet count of 1,000 because there is no cell counter which will give you platelet count of 1,000. Even if you put water through the machine, you will get at least 3,000. But to my luck, this idiotic cell counter gave me a platelet count of 1,000. Next day, 1,000. So the father says, okay, we'll give him platelets. I said, can I have a look at the peripheral smear? Because, how long do you want? I said, another 3 hours, I'll make this peripheral smear. I'll look at it and I'll call you back. And then we'll decide on the platelet transfusion. So the question is, are cell counters reliable when there is thrombocytopenia? Most of you have been told no, but I'm going to tell you it is the most reliable, provided you look at the right place. So you must realize that platelet histogram has a pattern. This is a normal distribution. Most of the platelets are less than 10 femtoliters. So when you have a normal distribution, this platelet count of 76,000 is not going to change even if you do any other method. Sometimes you can have, this is a patient with a platelet count of 21,000, normal distribution. Even if you do any type of method of platelet count, you are not going to get more than 21,000. This patient also distribution is mostly less than 10 femtoliters, but there are some population increasing between 10 and 20 femtoliters. That's because this patient has got few large platelets. But the fitted curve will accommodate for those large platelets, and the platelet count is not going to change whatever method you can do. So when you get a histogram like this, where the events are mostly between 10 and 20 femtoliters, there is significant platelet isocytosis. This is when you need to do a manual platelet check. Other cases that I showed you, don't even think about it because the histogram is the direct measure from the cell counter. But here you need to, because the manual platelet count in this patient was 2 lakhs. Here there is no fitted curve, but the distribution is normal. I would not look at the peripheral smear. And when you get a histogram like this, where the events are going to peak at 20 femtoliters, guaranteed red cells are contaminating the platelet count. And red cells in millions contaminating 1,000 platelets can be dangerous. It could be TTP. They are schistocytes. And the platelet count in this patient was actually 20,000, not 99,000. So I have been looking at this boy's smear from day one. Every day I have been looking at, normally I don't look at smears, but this boy's smear I have been looking because I know the father will call me. Now this is when the platelet count was 75,000. This is when the platelet count was 4,000. You can see that this guy's platelets have also changed morphology. Initially, he had normal looking platelets. They start becoming large. These are called large young platelets, which happens when there is peripheral destruction of platelets. The platelet will appear more bluish. So what is the significance of large platelets? Platelet counts can be unreliable because impedance may miss large platelets. So what is the solution? MPV. Can MPV be reliable? Okay, in some extent, but sometimes MPV will fail. For example, this patient has giant platelets. MPV is not that great compared to this. As the number of giant platelets, large platelet increases, the MPV increases. But MPV may not always be reliable. And some of the cell counters don't even give MPV also. Yeah, for example, that particular case, there is no MPV there. So what is the solution? Optical platelet count. So there are different ways of optical platelet count. One is by light scatter and one is by fluorescence. So Mindray and Sysmex uses fluorescence for optical platelet count, and Alinity, Advia and Horiba uses light scatter for optical platelet count. So here you can see a patient with Bernard-Soulier syndrome. Also my patient, not from the internet. And you can see that impedance was 8,000 while the optical platelet count was 88,000. Now here you can see a normal distribution, but we find that when there's normal distribution, the impedance platelet counts are higher than the optical platelet count. We realize that that is because the optical platelet count, which does by fluorescence, they eliminate a lot of small platelets because they consider that as background fluorescent noise or background light signal. So for example, in the next case, Wow. Fine. So you can see that there was a good agreement between the impedance platelet count and optical platelet count. But the interesting thing is, look at the smear, the platelet count is 90,000. There are 6 platelets in the smear. So wherever the platelet, whenever you use the equation is like this, 1 platelet per oil immersion field where the red cells have started to overlap. Where the red cells have started to overlap is equivalent to 15,000 platelet count. So where the red cells are going to overlap. So that's very important. So 15,000. So there are about 6 platelets here. Its platelet count is 90,000. Now, obviously, the impedance missed the large platelets and the fluorescent missed the small platelets. But look at the histogram. Histogram tells you, look at the smear. So in our place, when the platelet count is low, look at the histogram. If the histogram shows normal pattern, release the platelet count. If the histogram shows there are giant platelets or large platelets, do an optical platelet count and release the optical platelet count. But when the histogram is showing a significant platelet anisocytosis, look at the smear. Yeah, so this is the boy. And here you can see the platelets. They are significantly blue. So there was something called IPF, People started saying that IPF is a parameter which predicts platelet recovery. And the study that was done, what I'm seeing there and here is different. So, they said that the platelet count will recover in 48 to 72 hours in dengue patients. I've got this father sitting on my head and I've only given him 3 hours. I can't tell him that IPF is high and the platelet count will recover after 48 to 72 hours. Now, this patient's 2 platelets are very young platelets. He is having dengue. All the platelets are getting cleared every day. And these platelets are probably produced less than 1 day back. Both are young platelets. Actually, in the definition of IPF, it should be IPF. Both are IPF. But this will never be counted as IPF because only large platelets will be counted as IPF, even if they are not immature. Oh, sorry, I didn't want to use the word immature. I was trying to avoid that. In all my life, in hematology, 35 years, I have called platelets as platelets. I have never called them as mature platelets. Mera beta, no, I have not called them as mature platelets. So obviously, there is nothing called immature platelets. Yeah. So this, though it's young, will not be called as IPF. Because IPF is only when the platelets are large. So it's a pseudo parameter again. Okay. So many studies have also shown that IPF does not predict platelet recovery. So let's ignore IPF. And we also showed that patients who have got giant platelets, large platelets like this, their IPF are more than 60%. So IPF is nothing but large platelets and not young platelets, if they want to call that as young platelets. If you want to call something immature, this is immature. Proplatelets. Oh, they didn't come. Here it came. So these are proplatelets. So, normally the megakaryocyte from the marrow releases this. They don't release platelets directly. They release this. This goes and sits in various tissues. Favorite tissue is lung. So when you yawn, when you sneeze, when you cough, the lung will produce these platelets from proplatelets. So one proplatelet may produce 100 to 200 platelets. So, but when there is stress, then marrow will reduce. The megakaryocytes in the marrow will release platelets directly, and those platelets are large platelets. Okay, so histogram. So now coming back to my boy. So this is the peripheral smear I saw in him on that day, and the platelet count was 1,000. Have you ever seen platelets like this? Almost looking like lymphocytes. Intensely staining protoplasm. So my professor, that is Dr. Annie, she always tells me that these platelets are called stress platelets. What does it mean? It basically means the platelet count recovery is imminent. So I called the father, I said, I'm seeing stress platelets. What does that mean? I said, platelet count recovery is going to be very soon. So he said, how soon? I just somehow said 6 hours. So he said that, okay, 6 hours later we'll collect the blood and see the count. I said, poor fellow, tomorrow morning anyway he's getting poked. Why do you want to get poked unnecessary? Tomorrow morning we'll check. So he agreed. So that night I could not sleep. So at 2 o'clock in the morning, I called the technician. I said, go and collect the blood. I want to know the platelet count. So platelet count was 25,000. Yeah. So you must realize that it's not arrogance, because that's the best part of hematology. When something happens in hematology, there is nothing in absolute, the platelet count. Something else is also happening in the blood. And these changes are happening. These lymphocytes appear in the blood. These are called as high fluorescent lymphocytes, and they have a particular pattern. It's like an hourglass pattern that they have. The monocyte comes between the two lymphocytes. They are actually not lymphocytes, they're actually monocytes. The high fluorescent cells are actually monocytes infected by dengue virus, because dengue virus is monocytotropic. So they get inside the dengue virus and they multiply and take up more fluorescent dye, RNA dye. And that's why they hit the roof. So these cells, and you can see that that's a pattern that you get, which are called as high fluorescent lymphocyte. So you can have HFC, you can, even the cell counter will give you HFC percentage. And this is the dengue cases. You can see that reference range is up to 1. In dengue cases, they're quite high. So you can see that in dengue cases, there's a high increase in HFC. And at the cutoff of 1.4, the diagnosis of dengue can be made, just looking at that pattern, at a cutoff of 1.4. And the interesting thing is, as the infection or NS1 goes up, the HFC goes up. And when the NS1 comes down, or the infection decreases, the HFC comes down. And the best part is that if you look at it every day, oh sorry, it's not changing here. The platelet count is a mirror reflection of HFC. So looking at the HFC, you can actually predict when the platelet will recover. Okay. 42-year-old male, acute myocardial infarction, waiting for angiogram, loaded with antiplatelet agents, aspirin 300 milligrams, clopidogrel 300 milligrams. And before the procedure, they want to know whether the antiplatelet agents or drugs are working, because they don't want to do an angiogram when the platelets are active. So we do all these tests. We have facilities to do all these tests, including flow cytometry, and we give the report. The platelets are not responding to both aspirin and clopidogrel. So the cardiologist is quite worried. He said that, okay, what should I do now? I said, sir, you are the cardiologist, you are doing antiplatelet agents, you have to decide. Oh, maybe I'll increase the dose. I said, that's for you to decide. But you have been giving us a lot of reports, you have been giving us opinions, you have to tell me what to do. So I said, sir, I'm not a cardiologist. Anyway, you have to do something. So my professor, Dr. Annie, always says, when you're in difficulty, look at the peripheral smear. And the peripheral smear gave me the answer. Large platelets. You must realize platelets are loaded with RNA. 9,000 transcripts of RNA in a normal platelet. So these large platelets will have 20,000 to 25,000 transcripts of RNA. Some of the RNA are also manufacturing COX. Some of the RNA also manufacture P2Y12. So when the aspirin goes into the blood, half-life of 6 hours, but once it enters the platelet, it neutralizes the COX and it's finished. After that, there's no aspirin left there. Now this platelet will produce new COX. Now you have to wait for the next day's aspirin to come. So I gave him the answer that instead of increasing the dose, why don't you give aspirin twice a day? And I sent him an article also. Aspirin twice a day keeps a cardiologist away, written by Paul Harrison in Platelets. And it worked. It worked. So you can see, I live a dangerous life, but thanks to the cell counters. Okay, now Chepsi and Shashi will know this story. I mean, they will not know the story, but they will know the person. 70-year-old retired and highly reputed professor of CMC undergoes a resection of colon with anastomosis. He spikes on day 4. Day 4 spikes, when there is anastomosis, is always anastomotic leak. Always. Surgeons say that day 4, day 5, if there is a spike in fever, it is anastomotic leak. Take the patient for re-exploration. The morbidity after re-exploration is high. And if you don't do re-exploration, mortality is 100%. So, and interestingly, the CRP is high. So they have decided, okay, we have to, it's an anastomotic leak, we have to take him for re-exploration. But there's one idiotic intensivist there. He said, let's ask Sukesh. So, what? Look for toxic neutrophils. Because when there is an anastomotic leak, there will be bacteria. Bacteria will produce toxic neutrophils. But the WBC count has been always high, probably surgery. So here is what I see. What do I see? Neutrophils are looking very calm. There is no increased fluorescence of neutrophils. But what I see is there are reactive lymphocytes. They are not like the dengue lymphocyte, they are reactive lymphocyte. Okay? So this is not bacterial, but this is viral. So Shashi, this is viral. Now, obviously, senior professor, I didn't want anything bad to come to me, so I thought I'll run it one more cell counter. Same thing. Overlap between lymphocyte and monocyte indicates reactive lymphocytes. So in cell counters like Horiba and Beckman-Coulter, when there are reactive lymphocyte, the lymphocyte-monocyte population overlaps, almost like a teardrop. So now I am confident that this is. So I call them and say that this is not bacterial. I mean, I didn't say that this is not anastomotic leak. I said this is not bacterial, this is viral. So initially the registrar says, are you sure? Then finally the surgeon comes and says, then the professor of surgery comes and asks. Then there's another professor who retired and came just for the surgery. He also asked, are you sure? His wife was my colleague who retired. So I said, your wife only taught me this. So he kept quiet. So this gentleman was discharged 11 days later without any re-exploration. So now there's a study going on in GI surgery on how cell counters can predict anastomotic leak. Okay, this is another interesting story. 1 year, 2 months with high count. I get a call from the pediatric infectious disease doctor that this patient has got fever. Your registrar has reported blast. Can you look at the peripheral smear? So here, you can, obviously there's a reason because there are reactive lymphocytes, which sometimes a morphology, young registrar who's looking at it may call it as a blast. So I have been looking at it and I called it as a, I didn't look at the smear, I looked at here, I said, okay, the neutrophils are reactive, the lymphocytes are reactive, but what caught my attention was platelet count was 10 lakhs, 9 lakh 39,000 with normal distribution. So, sometimes, you have to be very lucky to be at the right place at the right time. So when me and Shashi were learning, Dr. Annie, whenever we used to see a case like this, Dr. Annie will say this child has got pertussis. I think after that time when we were there, after that pertussis disappeared, so subsequent people who also got to work in the same lab, they would not have experienced this. So I was probably the last set of people to understand that when there is pertussis in a child, you can get thrombocytosis. The proplatelets in the lungs, you cough and the platelets keep on coming out. So I called the fellow and I asked, does this child have a cough? I mean, normally the question is, does the child have a whooping cough? But I felt a little silly to ask that question. So I said, this child has a cough. Yeah. You mean to say like a whooping cough? Yes, I said, yes, whooping cough. You think it's pertussis? I said, it is pertussis. So in pertussis, you need to send for molecular testing. So he sent for molecular testing and came back as pertussis. Fine. Okay. This is head of neuro ICU. So the thing is, I'm not very popular with infectious disease department in my hospital. Because many times they are seen a consult, they are not able to give a diagnosis. Then after that, these type of people, they call me. So neurosurgery head says, calls me and sends a message, hospital number, patient has 104 fever, procal normal, no source of infection that we can find. So I look at the cell counter, okay, some reactive neutrophils, some reactive, there is lymphocyte monocyte overlap, there is some reactive lymphocytes also, reactive neutrophils, and the white cell count is on the higher side. Okay, just for confidence, I run it on other cell counter, neutrophils are again reactive here, and there is some reactive lymphocytes. What caught my eye was again, what is the age of this lady? 48. I think that was 48. Yeah, 48-year-old lady. So, whooping cough, pertussis, we only hear in children, So, I didn't want to make a fool of myself. So, I called him and said, Jay, does this lady have a cough? He said, no. So, I said, okay, fine. Maybe not pertussis. Maybe it's a good idea to do a chest X-ray, Chest X-ray is clear. You tell me what you want. He's very brusque. Tall guy, very tall, taller than Shashi. I said, what do you mean? I said, normally when we see such a thing in a child, I will call it as pertussis. Okay, what should I do next? I said, send to Balaji for molecular testing. Hats off to you, pertussis positive. It's not possible. Even I can't believe it. So this is what Shashi mentioned. Some rare phenomena that will happen in your life. But this rare phenomena has happened to me many times in life. Yeah. That's it. It was pertussis positive. Okay, you want me to stop or? Okay, another colleague post-chemo, drop in hemoglobin. She's undergoing chemo. Hemoglobin is 5.4. She's very unwell. She's tired. And the husband calls and says that I am bringing her. Can you keep 2 units of pack cells ready for transfusing? So, no, because, I was, normally they call other 2 colleagues, who they are mostly in blood bank, but they were not there. So he called me. So I had the hospital number. So I looked at, obviously iron deficiency, she's on iron, but iron deficiency. Now the issue is that we always talk about iron deficiency as a very easy diagnosis. All teachers are here, students are here. We are always taught microcytic hypochromic anemia with anisocytosis. It is fairly simple. But what is very objective on the smear is something that we ignore. The most objective thing that you can see in the smear is anisochromia. The color is so different in iron deficiency. In thalassemia, you will never see anisochromia, even if it is thal major. Size, sometimes you bring one lymphocyte nucleus next to the red cell and say, oh, it's subjective. Samay aayi? Huh? Yeah. So, okay. So what I do is generally I sometimes look at the peripheral smear. Now here is a gentleman who had anemia, 6.5, chronic renal failure. So when a peripheral smear is seen for a patient with chronic renal failure, the first thing that you look for is whether there's adequate reticulocytes or not. Because erythropoietin dose that he's getting or whether he's on erythropoietin is there. So you can see that there are 3 polychromatophilic red cells in the smear. So that reticulocyte is fine. Then what I see is anisochromia. I see red cells which are hypochromic, red cells which are normochromic. Now the issue is, did the normochromic red cells happen few days back? It's good news. Or did it happen, or is the hypochromic red cells that happened few days back? Suppose the hypochromic red cells started 5 days back, that means his anemia is going to get worsened. So what do? You look at the reticulocyte, because reticulocyte lifespan is only 2 days. So you look at the color of the hemoglobin in the reticulocyte, and you can see that the reticulocytes are also anisochromic. There are some reticulocytes, which are normochromic, and some reticulocytes which are hypochromic. That's because the iron delivery into the red cells, erythroids, are not uniform in anemia of chronic disease. So this is anemia of chronic disease. This is not any other iron deficiency anemia. So the opinion given to the nephrologist is that erythropoietin is adequate, but there is iron deficient erythropoiesis. So of course, he was a cardiac patient, so he was given red cells, pack cells, but in a matter of 2 weeks, his hemoglobin came to 11.2 because they started treating him with iron during dialysis, parenteral iron. So this also is similar. There is iron deficient erythropoiesis. This is clear-cut iron deficiency. All the reticulocytes are hypochromic. But here you can see that anisochromia is there, but there are hardly any reticulocyte. So this is a patient who will require extra dose of erythropoietin, and if he's not erythropoietin, you have to start erythropoietin. Now, can we do this without looking at the peripheral smear? Yes. Because there is a parameter called as CHR or RHE. And CHR is directly measured, RHE is calculated. That is reticulocyte hemoglobin content. Hypochromic reticulocyte is the earliest indicator of iron deficient erythropoiesis. You know, somebody will ask you what is the gold standard for iron deficient erythropoiesis? Is zinc protoporphyrin. That is the same as hypochromic reticulocyte. Same. So identification of hypochromic reticulocytes is the earliest indicator of iron deficient erythropoiesis. Iron deficiency anemia may not happen, but there is iron deficiency erythropoiesis happening. And the cell counter can give you that information. So, yeah. So this lady, I look at his peripheral smear, she has got hypochromic red cells, but she also got normochromic red cells. And the reticulocytes are well hemoglobinized. All the reticulocytes. There's no hypochromic reticulocyte. All the reticulocytes are well hemoglobinized. And the reference range for CHR is actually 33 to 35. Now, looking at the reticulocyte, I can't say whether this is 33 or 35. But I know that it is between 33 and 35. But, you know, I want to tell her husband, who is also a physician, that, you know, her new red cells are fantastic. Do you really want transfusion? But when I look at the RHE, it's not even 35, it is 42. I called him and I said, don't come. The new red cells are fantastic. Your hemoglobin is going to be very normal the next day. The hemoglobin 2 days later was 8.2. So this is avoiding a transfusion. I can look at the cell counter data and I can give a report. Iron deficiency anemia, patient non-compliant to therapy if on any. I have done that. And I get calls from the obstetrician or, no, patient is saying she is having medicine. I said, no, she is not having. If she takes iron, I can see it on the reticulocyte. Immediate. 2 days. Okay, this is a story which most of you must have heard. Give me 2 minutes, I'll finish this story. And that's the last slide. Can I have 2 minutes? Okay, fine. Okay, Joe has told. So this is a story that happened when I was in Australia doing my fellowship in hematology. Same place where Shashi did the fellowship, maybe almost 7 years back. So at the night, I get a call that can you have a look at the blood film? There's an irritable child. So we are very happy to take that call because, you know, though it's abnormal, you know, they pay you $400 for abnormal call. So we are very happy. So we go, take the, and we, you know, $400. Suppose you stay beyond 4 hours, another $400 are added. But this is only a 10-minute job, but $400 are there. So we're very happy to do this. So I go look at the peripheral smear and what is so simple? There is blister cell and bite cell. That's why the child is irritable, jaundiced. So I called the resident. I said, oh, you know, this child has got G6PD deficiency. Okay, fine. So then he said, just hold on. So that is, I say, commonly seen with G6PD deficiency. Then he comes and tells, it's a female baby. So then, you know, slightly difficult situation. So I said, you know, autosomal recessive types of G6PD deficiency are also known, this thing. So then slowly, sheepishly, I changed my diagnosis. I'm typing my diagnosis to acute oxidant hemolysis. I didn't put G6PD, I just put acute oxidant hemolysis. So he said, oh, what do you mean by acute oxidant hemolysis? So I said, you know, there is a lot of, you know, some drugs, some chemicals, some food can have a lot of toxic oxygen radicals, which will denature the hemoglobin and convert them to Heinz bodies. And Heinz bodies are eaten up, and that's why you get blister cells and bite cells. Okay, so he said, can you give me example of some oxidant drugs? So have you ever read G6PD from any books? Williams, Dacey, DeGrucci. So they have a list of oxidant. You know what is first in that? Fava beans. So obviously I started with fava beans. Then I realized I made a fool of myself. This is only a small infant. So I started with fava beans. Anyway, I opened the book and gave him a list. He said, can you just hold on for a minute? Then he goes and finds out that this is a second child of the mother. The first child was 3 years back and was wearing the clothes of the first child, which was kept in a box full of naphthalene balls. So this is what I call experience, you know. So what happened in 2003 when I was back, Koshi George, who is a pediatrician, he's now working in Kotagiri. He was in Tejpur. He came back to do MD pediatrics. He called me one day and said, Sukesh, can you have a look at the peripheral smear of this baby, jaundiced? So I look at the peripheral smear. I say that this is G6PD deficiency. Then he said, it's a female baby. I said, go and ask the mother where is the second child and wearing the clothes of the first child. 10 minutes later, he calls me back and said, how did you know that? I said, a good morphologist can look at the peripheral smear and tell what a child is wearing. Okay. You can see these cells in the cell counter also. So cell counter is the first screening test where results are available within 1 minute of sampling. Whether it is sepsis, whether it is malaria, whether it is viral or bacterial, there is nothing better than cell counter to tell you that. So I hope I have answered your hope, Shashi. Thank you very much.
Okay, Sukesh, is there any time for any questions?
Ask, sir. Anyway,
Yes.
I have...
Yes, anyone? Please. Okay, I have a question.
Yes, sir.
Anyway, which I'll start from. I've got several questions, but one question is that you mentioned something about the infected monocytes.
Yeah.
Producing the figure of 8. And later on, you in the last few slides, you
Yes.
said that it produces a teardrop and almost similar to the figure of 8. How do you differentiate the two?
So, sir, that is, one is a fluorescent cell counter, which gives the figure of 8. Because the what happens is, the infected monocytes are continuing...
That I understood.
Okay. So now, the other one is got nothing to do with fluorescence. It is based on the scatter and size. So when the reactive lymphocytes come on the top, they come between the monocyte and lymphocyte. So the lymphocyte population merges with the monocyte, and monocyte usually is slightly slender. So it will give you a teardrop appearance.
Okay. One more question regarding thrombocytosis in a child.
Yes, sir.
See, why doesn't other respiratory infections with cough produce thrombocytosis?
So I have definitely asked that question, and the answer to that question is probably there's something in the pertussis virus, one toxin, which is causing thrombocytosis, because otherwise that adult will not have thrombocytosis without cough.
Okay, that's not the point. The point is that I have seen a few cases of children with respiratory simple cough and all
Yes, sir.
that having 11 lakhs.
11 lakhs, okay. So that is probably explained by the proplatelets in the lungs.
But you said it's diagnostic of.
I mean, that's what
pertussis.
Dr. Annie said. Just find out whether the child has got pertussis.
Okay. Do you get the point?
Yeah, I got your point. Of course, pertussis is not a difficult diagnosis for the pediatrician because the presentation is very significant.
But in my experience, I haven't seen thrombocytosis, but I have seen blood picture just like CLL.
Okay.
Very high count, lymphocyte count. Recently, we had a case when I was at Amala with this sort of thing, and the only thing it is given in the textbooks also.
Yeah.
I simply asked them, does the patient have pertussis? Is it a child? Then they said it was a child and it had cough.
Okay.
I don't know what transpired later on.
Because I don't think so there is any other test for Bordetella pertussis other than nucleic acid testing.
I think it can be cultured, I believe.
I don't know, sir.
It's a bacteria.
Yeah, it's a bacteria, but maybe a fastidious organism or something like that.
Okay, anyway. I don't have any other questions. These were genuine doubts which I had. Anyone wants to?
Good evening, sir. Thank you for such an inspiring talk. I am a huge fan. Sir, to continue sir's point, we had a pulmonologist who used to send us samples. Mostly in tuberculosis also we saw like lymphocytosis along with thrombocytosis. So today you talk about proplatelets and cough, somewhere it links that finding as well. And my question was, sir, about the platelet counts on smear. So when we were going for NABL, we tried to, include that in our protocol, but the auditor, we got an observation that we could not substantiate it, sir, to prove. So one question was how to do exactly the platelet count on smear. And the other question related to it was the field of view of the microscope. Does it change that formula for each platelet being 15,000 where RBCs are just overlapping?
Yeah. So first of all, the what do you call extrapolated platelet count from a smear is not a accurate test because there is no quality control for it. So it can't be. And also it's a very calculated parameter. You can't calculate CV. So if you want to put a parameter which has got a quantitative value, you have so many other things to follow. So it's not allowed as a this thing. But if you can put it as a part of an SOP for platelet count. Yes, so there is a reference for the platelet count of 15,000 per cubic millimeter if the platelets per platelet where the RBCs are just overlapping. And RBCs can overlap not in one place depending on the hemoglobin. If the hemoglobin is low, it will start overlapping further down the body of the smear.
Thank you.
Shall we conclude then?
Fine.
Okay, thank you very much, Dr. Sukesh.
Thank you so much. Doctor, she will be back. May I request, sir, certificate. May I request Dr. Joy to please felicitate our speaker? Manu, can you get it? Dr. Sukesh and Shashikant, after we'll give later. Sir is coming down. Thank you very much, sir. So moving on to the next session, may I please request Dr. Vinayaga Murthy to come on stage. May I request Dr. George to chair the session, please?
So good afternoon. So we will be shifting to another area of talk. I welcome Dr. Vinayaga Murthy, Professor of Head of the Department of Biochemistry, ICMRG, and Puducherry. So please.
Thank you, sir. Very good evening to everyone. As an outset, I thank the organizers for the opportunity given. After hardcore hematology discussions, we just move on to biochemistry part. I think we have very thin biochemists here. Majority are pathologists. So I'll be discussing paradox values in biochemistry that we have notified. We see these paradox in most of the parameters, but still I thought we'll discuss two routinely day-to-day parameters that we encounter in our laboratories, that is on bilirubin and glucose values. A 58-year man with the chief complaints of right leg swelling and abdominal distension with breathlessness was admitted in our hospital. These are the main problem that he has encountered. His history, he was a known diabetic. He was a known diabetic. Most important thing, he is a non-alcoholic because he is from Pondicherry, so I should stress upon this. Because why I said he is a non-alcoholic, he had a stress on examination. His GMR value, glucometer values are confirming his diabetic status, that is around 260 milligram per deciliter. These are the systemic examinations. Investigations, no DVT, other things are almost fine. But USD abdominal says there is a chronic liver disease, and he has calculi in the gallbladder, so addressing of the cholecystitis. So these are the major findings. On investigations, we could see the WBC counts. On the day of admission, it was around 25,000. Later on, it's almost dropping down. Blood glucose values, it's almost towards the diabetic range. On treatment, it come down to 147. And there is renal dearrangements. You can see the glucose and the creatinine is elevated, but on treatment, creatinine is almost coming to the normal range. Other biochemical investigations, you can see the liver parameters. The total bilirubin level on the day of admission, it is around 7.5, then 8.2, later it is 8.8. Protein, total protein is almost normal, but it is in the lower range. Albumin is lower side. And the liver enzymes, AST, ALT, are suggestive of liver disorders. And alkaline phosphatase level is elevated, which is a clear indication of cholecystitis. So these are the other investigations. So with this, the conclusion, the diagnosis are, he has right eye cellulitis and acute kidney injury with stones in the gallbladder, which is an indicative of elevated bilirubin levels, as well as liver enzymes are elevated, and ultrasound is also suggestive of that. Type 2 diabetic, and he has microalbuminuria because his urine albumin creatinine ratio is between 30 and 300. Why this case is important for us? You can see in my previous slide, the liver function, we have reported only total bilirubin levels for the first 2 days. We have not reported the direct bilirubin and indirect bilirubin. Even though we are very confident he has liver dearrangements, his bilirubin levels are elevated, liver enzymes are elevated, both AST, ALT and ALP. The reason why we have not reported that first 2 days are this. You see, our direct bilirubin, which is one of the fractions of the bilirubin, total bilirubin, is higher than the total bilirubin level. It is constant for all the days. Whenever we receive the sample, he got at the first sample, he got admitted in 24th. First 25th, we received the first sample. Then we have as repeat sample on the same day in the afternoon. We got the same kind of result. That is, the total bilirubin levels are higher than, the direct bilirubin levels are higher than the total bilirubin levels. Then I told my technicians and PGs to do a serial dilution and check, to quality check whether is there any pre-analytical or analytical error. But even in the serial dilution, we went up to 1:15 dilution. We got the same pattern. Anyone has got such an experience with you, where you got your total bilirubin levels? Yes, so total bilirubin levels are higher than the direct bilirubin. So you can see here, with this, we got the confidence on the 3rd day we have reported. Okay. because it's almost coming to the normal range. So third day we have reported, then how we can explain this phenomena? Where you have your total bilirubin, because total bilirubin should be very less when compared to direct bilirubin should be lesser than the total bilirubin level. So how we can address this phenomena? We know that we have to go for the quality check analysis. We run our QCs on every daily basis. QC is correct. When we compare the other patient reports, everything is fine. We have sent all the samples in every day on daily basis to JIPMER and we rechecked it. Even the JIPMER reports are also in concurrence with our results. So quality wise, our in-house reports are fine. There is no error in the results. So we wanted to stick with our reports. Okay, so there is no laboratory error. How you can explain this phenomena of your direct bilirubin is higher than the total bilirubin level. So what could be the reasons? We go with our hit, right? Anything that which is not clinically correlating. First we have to go for the hit, that is hemolysis, icterus and the turbidity. So there is no hemolysis in the sample. On daily basis we have checked, there is no hemolysis. Lipemia, our sample is very clear. Of course, icterus is expected because he is a liver disease patient, so we found icterus. But icterus is, if it is interfering, it should interfere with both the fractions. Both your total bilirubin also will be elevated, direct bilirubin also will be elevated. But our case is very peculiar, where we are getting in a higher value only in the direct bilirubin levels. Right? So next, after checking your hit, then you have to go for the drug interaction with your reaction. So what method we estimate our bilirubin is the Vandenberg diazo methods. So these are the drugs that can affect the Vandenberg reactions. We checked with the clinicians and the case record. None of these drugs are used to the patients. So there is no drug-drug interaction or drug interaction with the analytical parameters. So our pre-analytical parameters are ruled out. That means there is no hemolysis, there is no icteric is there, but it should have been interfere with the both parameters, but it is not there. So drug interaction is also not expected here, and there is no lipemia. So how we can explain there is an increased direct bilirubin level when compared to the total bilirubin level? So what could be the reasons? So we want to go for the reflect testing. We went to the literatures. We found that it should be due to paraproteinemia. What is paraproteinemia? It is one such condition, well-known condition is our multiple myeloma, where a specific clone of proteins are pushed into the bloodstreams, which can interfere with our testing. Okay, that means because your paraproteinemia will be interfering with the diazo reagent, which can directly affect the direct testing, that is conjugated bilirubin. Thereby we can get high level of direct bilirubin when compared to the total bilirubin level. So how we can rule out or how we can analyze the paraproteinemia? If there is a paraproteinemia in the circulation, this is your graph, what graph you will be getting in your autoanalyzer. This is what they reported for the Vandenberg reaction. You can see there is an interference in your graph. So we checked our graph with our autoanalyzer graph. You can see it is a very plain graph. So there is no interference. There is no interference on both the days. So there is no paraproteinemia. I said my PGs, no, we have to look into some other things. But he is very confident. No, sir. We will do some other assays. And I said with the confirmatory assays, we have to go for serum electrophoresis. Okay, we will go for it. Then we did electrophoresis to find is there any spike in the gamma globulin regions, which is a confirmatory test for the paraproteinemia, which can interfere with the direct bilirubin level. We thought almost we were 90% confirmed that even though the graph is very blank, we were confident that we are going to get a spike in the gamma globulin region, which is an interference with the direct bilirubin assay. To our surprise, you can see our patient sample is almost as same as that of the control. So paraproteinemia is also ruled out. So how we can explain this situation? There is no pre-analytical error. That means there is no hemolysis, no turbidity, no drug interferences, no paraproteinemia also. Then how we are going to explain increased level of direct bilirubin level over the total bilirubin level in this particular patient, even though the diagnosis clear cut that there is an obstructive jaundice. But how we can explain the phenomena of direct bilirubin level more than the total bilirubin level? Patient is discharged because he has cured, but we stored all the samples, all the 5 days samples we have stored of the because of our academic interest. Then we went to the literatures. Then we found something called delta bilirubin. Anyone have heard of this delta bilirubin? Yes, this delta bilirubin is one of the fractions of bilirubin. We know unconjugated bilirubin, right, which is water insoluble bilirubin. Then we know conjugated bilirubins are two types. When one molecule of glucuronic acid is added, it is relatively soluble. Then another molecule is added, that is bilirubin diglucuronate. We call it as a conjugated bilirubin, which is water soluble. So this water soluble conjugated bilirubin is excreted in the urine, is cleared by the urine, whereas the unconjugated bilirubin is not excreted in the urine. We call it as an indirect bilirubin. So combining these two, the conjugated bilirubin plus unconjugated bilirubin together constitute to the total bilirubin level. Whereas in our case, the total bilirubin level itself is lesser than the direct bilirubin level. Then in the literature we found there is something called delta bilirubin. What is this delta bilirubin? When the conjugated bilirubin level is elevated, usually the conjugated bilirubin is cleared by the kidneys, that is, it is excreted in the urine. But when there is an obstruction in the biliary tract, it is not going to excrete it. So its level is keep on elevating in the blood, and it binds irreversibly with the albumin. It binds with the albumin. Since albumin half-life is almost 2 to 3 weeks, okay, roughly around 20 days, it binds with the albumin, and this delta bilirubin answer to your DISO test. So it gives answer to the DISO test, so that we are getting increased level of direct bilirubin. This is what literature said. So how to rule out it? Because there is no test for direct bilirubin, that is your delta bilirubin assay. There are some calculated parameters are there, and we do not have any reference values, because in day-to-day practice it is not measured because the level is very, very less. The level is very, very less in the bloodstream, so it cannot be measured. Then we have approached our collaborative department in the biotechnology Pondicherry University to set up an LCMS HPLC column for this to assay the delta bilirubin fractions in our 3 days sample. So what we have done, the 3 days sample along with 3 normal samples we have given to Pondicherry University to estimate the level of delta bilirubin in our patient. So they found that the delta bilirubin levels in the patient samples are relatively higher than the normal samples that we have given. So we have addressed the issue that this particular patient, there is an elevated level of delta bilirubin that contributes to the increased level of conjugated bilirubin when compared to the total bilirubin. So take home measure here. So don't always think that your direct bilirubin level should be lesser than the total bilirubin level. If you are confident of your in-house calibration, your analytical procedures and your quality testing, be confident on your reports and work it on towards the academic interest. There must be some reasons. Later on, we went to the literature. Literature says increased level of delta bilirubin is a clinically interest because it is a good sign of patient prognosis. Because our patient is also cured within 5 days. So elevated level of delta bilirubin is an indicative of very good prognosis when there is a cholestasis. So this is one of the important paradox that we got in case of the bilirubin level. That is, the total bilirubin level is lesser than the conjugated bilirubin. Another one. What is the paradox here in this case? The fasting sample is around 170, whereas after food, postprandial is 132. Is it possible? Is it possible or lab error? Yes, sir. So, how frequent it is and what is the significance of this? Because we ignore this, clinician ignore this. Many times when I give such kind of results, immediately my interns, the junior doctor said, sir, what you are giving like this? 2 or 10 milligram you give more, sir, because my consultant will scold me. I have to send repeat sample. It has a clinical relevance. But what it says, what is the importance of this? How many of you are confident in issuing such reports? How many of you are issued this report confidently? When your postprandial blood sugar is relatively lower than the fasting bilirubin. Reason? Yes, sir. Yes, sir. Yes. So mostly we think it is due to the analytical reasons, right? Either it may be pre-analytical error, there is a delay in the processing, or it could be due to the patient is giving the fasting blood samples, then he is taking his oral hypoglycemic drugs, or he is taking his insulin so that the postprandial level is coming down. It is not always true, because there are literature which says that postprandial blood glucose level can be less than the fasting blood glucose level in the normal phenomena. It is one of the physiological phenomena. What are the reasons? We will look into it. So, in the recent past, we are seeing such, we call it as postprandial hypoglycemia. This is also known as, how many of you are known about this particular name, that is called as reactive hypoglycemia. But in our case, it is not a reactive hypoglycemia, it is a reactive low glucose value when compared to the fasting. Then we thought, okay, we will have a analysis in what kind of pattern we are getting in our hospital. This is the pattern we got. So I told my PGs, please go back to the delta check and see what was our statistics in 2024. So out of around 8,000 subjects, we found around 3%, 3 to 4% on monthly basis, we found this kind of postprandial low blood glucose level when compared to the fasting reports. We have reported it because we are confident of our analytical procedures. We have reported it. Then further, we wanted to look into this paradox. From which department we are getting more kind of reports like this? Of course, from medicine and OG, because they are the one who send more fasting as postprandial investigation. So we get more patients or subjects from this departments, OG and medicine department. Gender-wise, more female when compared to the male. The reason again, more females are coming for testing. That could be the reason when compared to the male. Another interesting thing you can see, this is not only seen in diabetic range, even normal people, we are seeing this kind of reactive hypoglycemia, both in normal as well as the impaired or pre-diabetic range. So all the ranges, this reactive hypoglycemia is seen in normal as well as pre-diabetic as well as in non-diabetic patients. This kind of pattern we have observed in our hospital according to the 2024 statistics. What could be the reasons? One, as sir mentioned, that could be the pre-analytical error. Maybe there is delay in the processing or quality control issues, or it could be due to the medications. Because you give the blood samples, you take your medicines, absolutely your postprandial blood glucose level is going to be less. Another reason, it due to the gastric empty, very fast absorption. When you take high glycemic index food, it will be very fastly absorbed, very fastly cleared from the blood. Another important phenomena, what we are noticing, many groups have started working on this particular concept now, known as reactive hypoglycemia. What is reactive hypoglycemia? This is how the response, when you take glucose or when you take a carbohydrate diet, in response to hyperglycemia, hyperinsulinemia stimulated insulin is secreted. When this insulin is secreted, that insulin is going to clear your glucose from the blood. But when your pancreas is overreacting, hypersensitive, it is going to pour more amount of insulin. Thereby, you are going to get low glucose level. This is known as hyperinsulinemic normoglycemic status. This is known as hyperinsulinemic euglycemic status. That is why when it comes to the second hours, your blood glucose level is dropping very less when compared to the fasting blood glucose level. What is the significance of this hyperinsulinemic euglycemic level? Recent studies are bringing out that this particular status is the beginning status of your insulin resistance. Those who are having this particular kind of pattern, that is when your postprandial blood glucose level is lower than the fasting blood glucose level, you have a high risk of developing type 2 diabetes in near future. So these patients or these subjects has to be followed up. Usually we won't treat them. Sometimes even the patients are happy. We have seen sometimes the subjects are happy because after the my sugar is very low, right? But they are at the risk. They are at the risk. This is known as reactive hypoglycemia, where your pancreas is overreacting, pouring the insulin. Why? Because over the period, your pancreas is putting into a stressed situation to maintain the euglycemia. So it pours and pours and pours more insulin like this, then it becomes almost to the type 1 stage where you have hypoinsulinemic hyperglycemic, which we call it as type 2 diabetic stage. Okay, so we have to follow up such patients or we have to address the issue. And we also found whom we are getting more amount of this particular kind of reactive hyperglycemia. They are mainly hypertensive subjects and female with PCOD, obese individuals. That means who are at and first degree relative of diabetes mellitus. First degree relatives of diabetes, we have the statistics with us. Since we are in the process of publications, few reports I could not show. Almost 80% of the first degree relative of type 2 diabetic patients shows this particular kind of pattern, that is reactive hypoglycemia. That means when your postprandial blood glucose level is lower than the fasting blood glucose level, don't be happy, you are at a risk. And we clinicians has to address this issue. Either you treat them or you advise them for the lifestyle modifications. Okay. How we can monitor this? The better way to monitor this is insulin secretion. So such patients, what we can do, if you find the postprandial hypoglycemia or low glycemia, further follow-up, we can assay the insulin on 30 minutes basis. Give the sugar levels, give the oral glucose, then 30 minutes, first hour, 1.5 hours, second hour. If you measure the insulin level, see the peak where it goes. Accordingly, you compare your blood glucose level. Then from that, you can calculate your HOMO-IR. Then you can predict their insulin resistant status and likely to be diabetic status also we can bring them. And in literature, we found another interesting thing, that is estimation of 1,5 anhydro glucose alcohol. Okay, that is another interesting parameter. Estimation of this parameter will give us the index of glucose clearance in the blood, by which we can address this particular issue. So we have taken up this study, and that particular study is going on with the ICMR funding in our institution to this particular subjects. Okay, so this is many reports are started coming up now. That is, whenever you have a overt insulin secretion, that is postprandial hypoglycemia, you have a high risk of developing diabetes in near future. So in summary, again, when your postprandial blood glucose level is higher than the fasting blood glucose level, it is not always a laboratory error. It is a fact, it is a physiological phenomena. Maybe it may leading to a pathological status in near future. We have to rule out the underlying physiological cause. We have taken up a particular study on these things. So with this, two things we have seen. One is bilirubin level, where your total bilirubin level is lesser than the direct bilirubin level, whereas your fasting blood glucose level is more than the postprandial blood glucose level. Both are paradox, but we have a underlying scientific reasons for this. So my request as a biochemist, when your quality control is fine, when you are confident of your results, okay, don't hesitate the paradox, releasing the paradox result. Be confident, release the paradox as and when your quality control is fine, but look into the root cause. Okay, go back to the literature, show the academic interest, look into the root cause. Definitely you have a clinical significance. In our first case, elevated level of delta bilirubin is clinically important because it shows the prognosis. In our second case, a decreased level of postprandial blood glucose level is an indication that you are at a diabetic risk, even though there is a paradox values. Thank you for the opportunity.
Thank you for pointing out this odd situation come across about this common two parameters. In fact, I have a paper on this.
Yes, sir.
Lower postprandial.
Yes,
I published in 2000. So there were a lot of cases. Some of my students were coming and asking me, sir, I am getting this kind of values. What should I? I say, what we were doing, we were just reversing it. So
Yes.
when it postprandial comes less, we make it fasting, and fasting we put up.
That is what happened.
So we are served like that. Otherwise, clinician will go on questioning and we don't know. I say, you go on giving it, it is possible.
Yes.
So some people may come across such things, so they cannot have an answer. The general concept is it cannot happen.
Yes.
It is happening. Coming to the other bilirubin, delta bilirubin, I think there are certain analyzers, they are measuring this.
Yes, sir.
So those cases we did not come across such higher direct bilirubin above total. So that's my experience I have to share.
Yes,
Any other questions from?
Yes, sir.
Regarding that higher direct bilirubin, will it be same across other methodologies or it is unique to diaso?
Sir, it is common because the well-known standardized method is the diaso method, which we are commonly using it. Definitely, it is wherever the bilirubin part is reactive, it is going to be interfere with your results.
Such phenomena have been noticed in certain different conditions like high lipemic samples.
Yes, sir. But in our case, there is no high lipidemia.
It is common in this wet chemistries.
Yes.
But when you do it on dry chemistry, we don't see such a situation actually.
Yes.
It's not dry chemistry. I told you that they measure delta bilirubin also.
Yes, sir.
So that's why that dry chemistry that they do like that. But the other interference, lipemia, it affects other parameters also.
The issue with this delta bilirubin assay as such, we do not have a reference value to compare. Because the fraction in a normal individual is very less because the conjugated bilirubin is excreted in the urine. So even if it is there, the fraction is very less, which is in coming with the direct bilirubin fraction itself. But in our case, since it is why it is attracted our interest is the level is always consistently higher. Even after 1:15 dilution, we are getting the consistent value of more direct bilirubin level when compared to the total bilirubin. That is why it attracted our attention and we started working on it. Then because we are almost confident that it is going to be a multiple myeloma or other gamma globinopathies. To our surprise, our electrophoresis, there is no spike. That is why we thought of delta bilirubin later.
Thank you, sir. Two questions, sir. One regarding this delta bilirubin. What happened to the urine bilirubin levels over the time? Was it positive or negative?
Sir, actually, what happens in the normal situation when there is a conjugated bilirubin, the conjugated bilirubin is excreted through the bile, comes to the intestine, then goes to the blood circulation. It is excreted in the urine.
Yes.
So that is why we are getting very less amount, less than 4 milligram per deciliter. But when this conjugated bilirubin is elevated, in such case, in our case,
I understood that when it gets elevated, it binds with albumin, it's not getting excreted in the kidney.
Yes, sir.
So in this patient, from day 1 to day 5,
yes, sir.
What was the urine bilirubin? Was it positive? Was it negative and becoming positive afterwards?
Negative, 6th day, that is 28th, when he is almost ready for discharge, it is getting excreted.
Okay. Then it becomes positive.
Yes, sir. It is getting cleared. It is getting cleared.
Yeah, that's what
that is what it is a prognostic interest.
Yeah, that's what textbook says. When it was so far negative and it becomes positive, you should think of delta bilirubin. Fine. The second question, sir, regarding this post-meal glucose versus fasting glucose, the two important factors which we come across is the timing of the sample.
Yes.
So it should be exactly 2 hours. One. Second thing, patients are usually at anxiety when they are asked to give sample after a meal. They usually eat less.
Definitely, sir.
So these two factors we are very difficult to control.
Sir, that is what American Diabetic Association and WHO, even 2024 criteria, what they are saying, the concept of post-meal glucose is not at all recommended.
It's not for diagnosis.
It should be 24 to 75 gram glucose load test.
Correct.
But in a practical situation, we are not able to follow it. But if we are following the 75 gram of glucose load test, that will take care of all these pre-analytical errors.
So what methods you have employed to correct for those timing? Because in one of the test request form which you showed, it was 8:30 and 12 o'clock.
Definitely, sir. In our study, now what is recommended, that is 2 hours, 75 gram glucose load test we are performing.
Okay, thank you.
But in that we have a limitation. When we are performing the 75 gram glucose load test, we could not analyze that 5 anhydro glucose alcohol, which is of our interest. Why? Because it is present in the diet. It is an exogenous product.
Correct.
It is not endogenously coming. So we have 2 groups. One group we are analyzing with 75 gram glucose load test, whereas other thing we are doing what we are doing in the routine practice. They are taking their meal, carbohydrate meal. In that case, we are estimating this glucose alcohol, which is not metabolized.
Thank you, sir.
Hi, sir. I also did my PG in Pondicherry. So nice to see you, first of all. And moreover, sir, that scenario of that PPPs and fasting plasma glucose levels, okay, is very actually it's being encountered everywhere. And myself have done certain work on that also. So you are present in a very nice way. So I'd like to add on one more thing, sir. It has been also an observation, the physical activity part after taking the fasting sample.
Yes, sir.
And I mean the fasting sample is taken. After that, a physical activities of a good grade is done. Then taking the PPP sample, that can also lead to this kind of pattern.
Definitely, sir. So the postprandial glucose values are going to be affected by the carbohydrate load. Second, the intents of the glycemic index of the food. Third, physiological as well as mental stress of the individuals. To buffer all these situations only, we have a clear-cut recommendations by the ADA. Glucose load should be uniform. That is, we have to give 75 gram glucose load. That has to be dissolved in 200 ml of water. That should be consumed within 10 minutes. There should not be no vomiting. During the span of 2 hours blood collection, the subject should not do any physical activities. That means physical activity in the sense, vigorous physical activities. They should not sleep. They are permitted to do the routine work, like they can walk here and there, they can read newspapers or whatever other things can be done. So if we can take care of all these guidelines, definitely that particular part can be.
I think I can give you a reference for that also, sir.
Yes.
In the textbooks of endocrinology, Williams, they have been telling this point particularly in such a way because of the physical activity part, the GLUT4 expression, when they have as a protein also.
Yes.
They're telling some kind of, I forgot the name, only the last D1 I know right now. Okay. So maybe C1, D1, something like that. That protein get activated because of this kind of physical
Sure.
activity, and that will increase the glucose uptake also.
Definitely.
So if you add to your study, it will be more useful also. So wonderful study. Wonderful
Means
study.
you are saying more insulin sensitivity.
No, muscle uptake of glucose.
Okay.
That can also
Definitely. Definitely.
So it's a wonderful study. If it will be nice if it has been absolutely covered on that part also.
Sure.
And moreover, in vitreous and dry chemistry, people used to tell the delta bilirubin effect is kind of comparatively less,
Yes.
but it's nothing like that. Delta bilirubin is always delta bilirubin.
Yes.
It is always a kind of algorithm-based diagnosis. Okay, thank you.
So actually, in the literature, you can come across all these things.
Yes, sir.
See, I tell you, conclude, and there is one question online. I will answer that also.
Sure.
So there are papers on this lower postprandial glucose. It's possible. And what you are saying about all these factors is all very negligible because most of the cases, many of the hospital I worked, in health checkup cases, most of these cases come out. So they are with us. Once they take the fasting, we provide them the food in our canteen and then take the postprandial. It is possible. A lot of papers are there. As you said, it's a physiological phenomena. It's a pre-diabetic condition. You told that.
That's what.
So lifestyle change otherwise, and it is inherited also sometimes from those families. These are all proven since a long time. A lot of papers are. It's nothing related to the exercise or other things, because most of these people are mostly we found the health checkup groups, these incidents we note, because it's easy to collect the data from them.
No, the take-home
So
message-
then a lot of publications are there. When I published that paper, I came across, and there is an online question on this bilirubin. One Dr. Archana is asking whether delta bilirubin is similar to macroprolactin and macro CPK. What is your answer? I don't think it's.
I don't think so, sir.
So that's the answer.
Yes.
Okay.
Thank you.
Thank you. Thank you.
Thank you, Dr. Can you please stay on the stage? Thank you, Dr. Vinayagamurthy, and thank you, Dr. George, for chairing the session. May I request Dr. George to please felicitate our speaker? Thank you, Dr. George, and thank you, Dr. Vinayagamurthy. So, may I invite Dr. Anju to please come on stage for the next lecture? And may I request Dr. Sankar to chair the session, please?
Thank you, Shama. It is my privilege to introduce Dr. Anju CK, who is Assistant Professor in Government Medical College, Kottayam, where I have worked. I worked with her for more than 8 years. She has got a passion for hematology, and she is a good cook as well, and innovates there. Over to Anju.
Thank you, Shankar sir, for that kind introduction. Good evening, all. Today, I'm going to present a study which was done in our lab, where we compared the platelet count by optical method and impedance method, and which was compared with the gold standard, that is a peripheral smear count. Now, We all know that the platelet count is critical in diagnosing hemorrhagic diseases, coagulation abnormalities, and various autoimmune disorders. Now, it is very crucial in the pathogenesis of cardiovascular disease, cerebrovascular disease, infections, and tumor invasions. Now, for the postgraduates, there are different methods for platelet enumeration. The standard reference method is the flow cytometry, but that is not practically possible. Now, the gold standard is the platelet count by peripheral smear or the platelet microscopy. Then we have other methods like platelet impedance that already been discussed. Then platelet count by optical method. And the hybrid method where the Mindray 760 machine uses is the hybrid method where the count obtained by the optical method is analyzed by the machine and compared with the impedance, and the value is obtained. And platelets can be counted by fluorescent method also. Now coming to the study. Our objectives were to describe the causes of false count in automated hematology analyzer, to evaluate the diagnostic performance of impedance and optical platelet counting methods, and to compare the mean difference in the platelet count obtained by above two methods in a Mindray BC 760 analyzer. Now we have studied a total of 100 samples in our lab, and the analyzer used was Mindray BC 760. The first 50 cases were selected randomly, and the remaining 50 cases were selected which showed thrombocytopenia by impedance method. And in all cases, the platelet count obtained by impedance method is compared with the hybrid method or the optical method, and it was compared with that of the peripheral smear count. The study design was diagnostic test evaluation. Now coming to discussion, a few of our cases. A 30-year-old male presented with fatigue, and he had a history of hemorrhoids also. The platelet count obtained by impedance and the hybrid method showed some discrepancies, and there was the platelet count obtained by peripheral smear was 15,000. Now, the peripheral blood picture showed a microcytic hypochromic anemia, and there were very small microcytes also. So here, the discrepancy may be due to the small microcytes which fall within the platelets size, and the threshold can be falsely interpreted and causing a spuriously elevated result. Now, other causes of falsely elevated platelets can be fragmented RBCs, as in MAHA, then cytoplasmic fragments of blast cells in leukemia, usually after a chemotherapy, and lipid particles in a postprandial sample. And even fungal and yeast forms and bacteria can also cause furiously elevated platelet counts in the impedance by impedance method. Now, this is another case where a 10-year-old child presented with fever and vomiting. Here also, there was discrepancy between platelet count obtained by impedance method and hybrid method. Here, the MPV was slightly towards the higher side. And on examination of the peripheral smear, they showed large platelets. And in peripheral smear, there were small clumps also. So the platelets with a diameter exceeding the diameter of the normocytes may fall outside the threshold of platelets by impedance method. So this is another case where a 25-year-old female worked up for an accidentally detected thrombocytopenia on a routine antenatal checkup. Here, both impedance method and optical method showed thrombocytopenia, but on the peripheral smear examination, there were large sheets of platelet clumps seen. So the take-home message is the peripheral smear remains an indispensable gold standard for the discrepancies in platelet count. Now this is another case where a neonate presented with hyperbilirubinemia. By impedance method, the platelet count was towards the lower side, lower limit, and by hybrid, it was almost normal. The MPV was normal, but on peripheral smear examination, there were fibrin strands with platelet trapping, and also there were few clumps. So actual platelet count is more than from the hybrid and the impedance method. So this is another cause for falsely low platelet, that is a platelet satellism. This is actually not from our slide. This is a picture from the internet. So the statistical evaluation of the diagnostic test evaluation showed a true positive in the first 50. I took the first 50 cases, and in there the true positive was 10. False positive was 2, and false negative 1, and true negative 37. So from this, the sensitivity of platelet count by hybrid method was 90.9%, specificity 94.8%, and with a positive predictive value of 83.3%, negative predictive value 97.3%. Now, we did a comparison of platelet count by impedance and optical method by the statistical analysis, that is a paired t-test. Here, a total 100 samples is taken, and the mean difference of the platelet count by impedance and optical method was found to be significant, and the mean value was 30 into 10 raised to 3 per microliter. That is about 30,000. Now, this is the different range of platelets. That is less than 50,000. We got only one cases, so the statistics could not be analyzed. So between 50,000 and 1.5 lakhs, the p-value was significant, and likewise from 1.5 to 4.5 it was significant, and above 4.5 lakhs it was 0.7074. So here the difference in the platelet count by impedance method and the optical method is significant when it comes to the lower limit, that is the thrombocytopenic level. So it is clinically and statistically significant. Now the take-home message is the optical and impedance method for platelet detection differ in their platelet count, which is significant in thrombocytopenic ranges. The false count can arise in impedance method, leading to misdiagnosis if it is not recognized, and false low count should be identified to avoid unnecessary transfusion, invasive procedures, and surgical delays. False high counts can be present in cases of misthrombocytopenia, leading to inappropriate therapy. And Mindray's BC760 hybrid technology offers a dual channel platelet counting, which enhances the reliability of the platelet count. Peripheral smear, whatever be the analyzer, the peripheral smear remains indispensable as a confirmatory tool in all discrepancies. This is our team back there in Kottayam. Thank you.
Paper is open for discussion. Any questions? Did you check the histogram or MPV? As Sukesh was saying about the same thing, no?
Sir, I just studied the counts only.
he had shown the algorithm of how you use the histogram in comparison to count and also follow the MPV rule.
Okay, sir.
So I think added to that, I think the comparison is okay. Was there a bias in the study is my question, because you are looking at all symptomatic patients, no? Coming to the, it's not general population, no?
The first 50 cases were from general population, sir.
Okay, so there is no bias. Any questions? Or we'll conclude. Any comments, suggestions?
Anju, nice study. My only question is like about the sample collection and storage time. So was there any uniformity in which vials the samples were collected? Was it the same batch or same company? And how long it was?
It was not in same batch, madam. The samples were collected over a period of 4 months.
Okay, okay. And like when did you check the count or the peripheral? When was it prepared? Was there a uniform
The
time?
CBC was done within 2 hours.
Thank you.
So thank you all for listening to this lecture as well. I thank Dr. Anju. Please give her a clap.
Thank you, Dr. Anju. Thank you, Dr. Sangar, for chairing the session. May I request you to please felicitate our speaker? So this session will be the last session for the day, and it's Dr. Pradeep Suri. He has recorded his videos because due to some conditions he couldn't come, but he has recorded a video and he has sent it to us. So may I request to play Dr. Suri's session, please?
Recently based on the hemocytomorphometric findings. So first, the brief history of the patient. This is a case of a 16-year-old female. She had history of fever, loose stools 3-4 days back, and pain in the abdomen. On physical examination, the clinician found pallor to be 2+, icterus 1+, there was mild splenomegaly. These are the CBC findings of the patient. I just want to tell you that this patient had already come from a known corporate lab I wouldn't like to name, and the findings were slightly different. So the hemoglobin was 6.2, RBC was 1.63, hematocrit was 20, MCV 123, RDW 25.5, WBC 2970, platelet was 94,000 done by both optical and impedance methods. The immature platelet fraction was high, 32.4, and the DLC was normal. This is the machine printout. You can also see from here that the reticulocyte count was 2.9 and the nucleated RBC count was 28%. This is the RBC histogram. You can see that it's a pretty broad base, so the patient had marked anisocytosis, as is evident from the RDW. and most of the peak is to the right of the 100 discriminator. So the patient was having predominantly macrocytic anemia. The platelet histogram shows that on the right hand side it has not touched the baseline. So there is an abnormal platelet histogram, most likely due to giant platelets or macroplatelets in the system. WBC scattergram did not show differentiation between mono and lympho area. So the DLC was done manually. Rest of the scattergram is pretty normal. The retic scattergram showed slight increase in the LFR and MFR. There was increase in immature reticulocyte fraction. All the reticulocyte count was mildly elevated. As you can see from the green area here, the area of the immature platelet fraction scatter is pretty high, as we can see that the IPF value is around 30%. This is the WNB scattergram, which differentiates between WBC, nucleated RBCs and basophils. As you can see from the pink area here, the nucleated RBCs are significantly increased. They are around 28 per 100 WBCs. As you can see from the WNB parameters, the pink parameters is the nucleated RBC, the yellow is the basophil, and the blue is the WBC. These were the machine flags. The patient had pancytopenia. The WBC and WNB scattergram were abnormal. There was query of blast, although they were not seen on the peripheral smear. There were immature granulocytes. Nucleated RBCs were present. There were fragments and abnormal WBC histogram. So the peripheral smear was as follows. There was marked anisocytosis, marked poikilocytosis. RBCs were predominantly macrocytic with many ovelocytes, teardrop cells, fragmented RBCs and nucleated RBCs. There were areas of basophilic stippling and Howell-Jolly bodies were seen. WBCs were diminished and shift to the left. Platelets were diminished with many giant platelets. So our impression was macrocytic anemia with pancytopenia along with fragmented and nucleated RBCs. This is the optical RBC scatter plot from the same patient. As you can see, most of the scatter is in the top column there representing macrocytic anemia. So we ran a few more tests to reach the final diagnosis. So we first ran the obvious test. We ran the vitamin B12 folate. We ran the serum iron along with it also. The vitamin B12 levels were diminished. They were 23 picomoles per liter against a normal reference range of 150 to 750. So clearly this was a case of megaloblastic anemia. Along with that, we ran the LFT. The total bilirubin was 4.7. The conjugated was 0.57. So it was basically unconjugated hyperbilirubinemia. The haptoglobin levels were significantly decreased, 3.85 against a normal range of 32 to 205. There were presence of blood in the urine chemistry, significant amount of blood, and the G6PD levels were moderately less. They were 52 compared to a normal range of 146 to 376. So the patient had both megaloblastic anemia as well as hemolytic anemia due to G6PD deficiency. So we also ran a HB chromatogram. A2 levels were slightly elevated, they were 4%. But as we all know that in vitamin B12 deficiency also A2 levels can be mildly elevated. The CBC indices were not suggestive of a THAL trait, so we advised a repeat HB chromatography after correcting the B12 deficiency. Our final diagnoses were megaloblastic and hemolytic anemia due to vitamin B12 deficiency and G6PD deficiency. So the point here is that the previous lab had A, missed the nucleated RBCs, B, they had overcounted the WBCs because they were counting WBCs also, nucleated RBCs also into the WBC. And of course, the peripheral smear must not have been adequately screened also. So when you look at the histogram and scattergram, a lot of these things unearth even before you start seeing the peripheral smear. Just by looking at the histogram and scattergram, most of the diagnosis can be made even before you set your eyes on the slide itself. So with these words, I'd like to thank you. If there are any questions, I'll be glad to answer.
So thank you, Dr. Pradeep Suri. He is not able to join online actually, so regrets for that. So we declare the session closed, but before that, may I request Mr. Funny to convey the vote of thanks, please.
Yeah, good evening, everyone. As every good event has to close or it has to be paused till we go for the next thing, so this has come to a close. So as this informative and inspiring event comes to conclusion, I, on behalf of Mindray India, want to thank everyone who helped make Mind Manthan 2025 a huge success. First and foremost, I want to thank our esteemed faculty members. Your insights, expertise, and thought leadership have truly sparked new ideas and elevated conversations. We are grateful to all our delegates who are here in Kochi with us, thanking you for being here, participating and contributing with a lot of energy. At Mindray, our aim is to empower laboratory professionals with innovative technology to enhance the diagnostic accuracy and deliver better healthcare for all. So Mindray India will continue to organize such knowledgeable sessions, sharing platforms like Mind Manthan that promote learning, brainstorm new ideas, and make collective progress. Lastly, and most significantly, I want to thank the whole Mindray India and headquarter team. Your diligent effort and planning have made this event seamless and impactful. Let's forge ahead and make a healthier Bharat. So thank you once again to all of you, my colleagues from headquarter, my India colleagues, faculty, and distinguished guests and the participants. So we have our evening dinner also here in this same place. So I request each one of you, very personally, I invite all of you to join for a dinner. Thank you so much.
Thank you, Mr. Funny. Thank you, everyone. So we will depart now to meet soon. And you all can join for dinner. I think it's approximately at 7:38. So you can come down, change and come down, and we'll have some refreshment. Thank you.